Like what is the history? Is this a female patient that is 30, 40 years old and is pregnant and is presenting with this histology? So it will exactly be the same histology, but the history is going to help you out that this is not bullous emphygoid, this is more herpes gestationis, and even the immunofluorescence is not going to help you out because immunofluorescence is also going to show you the linear IgG and C3 epidermal junction in herpes gestationis. So those are known as the prodromal phase of bullous emphygoid or the articarial phase of bullous emphygoid. So when you look at this biopsy here, you go high power, you actually don't see any bulla here, but the patient is scratching quite a bit, so you see a lot of parakeratosis and hemorrhage in the stratum corneum. And then when you start looking at the changes within the dermis, you start seeing this type of eosinophils within the dermis. So perivascular lymphocytic infiltrate with a lot of eosinophils. So when you see that, the first thing is always that is going to come to your mind is a drug eruption or hypersensitivity reaction. Superficial and mid-dermal perivascular lymphocytic infiltrate with admixed eosinophils. The first thing that will be hypersensitivity. But you have to remember, like the other difference, seeing that is very more helpful in making the diagnosis or at least thinking about the articulated phase of bullous emphygoid. It is when you start seeing this eosinophilic exocytosis. So what do we mean by exocytosis is when the infiltrate is starting to go into the epidermis. You could have a lymphocytic exocytosis which occurs in the spongiosis and in a mycosis fungoides where it is called epidermal tropism. Or you could have a eosinophilic exocytosis. So when you start seeing some eosinophils also going within the epidermis, that is a feature that is commonly seen in articarial phase of bullous emphygoid. But again, it is not written in stone, it can also happen in a bullous arthropod bite. So you always have to keep that in your differential. But if you start seeing this eosinophilic exocytosis within the epidermis, at least think about bullous emphygoid, look at the clinical history, what is the clinical presentation of the patient, and talk to the dermatologist like would bullous emphygoid be in your differential, and if it is in the differential then they can do the DIF studies and they can send you the tissue in the Michel's medium, and if you do the DIF then you're going to see the linear IgG and C3 epidermal junction. So the diagnosis can be made before the bulla even came clinically, and that is not an uncommon thing to happen. So if you keep that in mind, you can present the differential diagnosis to the dermatologist or to the clinician, and then they can do the immunofluorescence studies, and that will help them make the diagnosis of BP much earlier. Now moving on to the next case here, you can see that this patient is presenting with these lesions on the elbow, and they are very, very itchy, and some of them are also on the extremities with some bulla formation. And on the trunk on an erythematous base. And one thing is that they are very, very itchy lesions. These are usually younger patients, not very old like the bullous emphygoid, so in the 40s, 50s. And if you look at the biopsy here, so again we know that we are looking at a bullous lesion because you see there is a subepidermal bulla here. So here you can see that the bulla is subepidermal. So like the next question is, do I see inflammation? Yes, I see inflammation. So it is not a cell tumor, it is a cell-rich subepidermal split. So next question is, what is the kind of inflammation? If it is eosinophils, we already talked about the differential diagnosis. Here we can see a lot of neutrophils. You can see there's a lot of neutrophils here. So now when you start seeing a subepidermal bulla with neutrophils, the next question is like, what is the location of the neutrophils? So here we can see that the neutrophils are filling the dermal papillae. So they are not throughout the dermal epidermal junction, but they are within some dermal papillae, and they are almost forming like a dermal papillary abscess. So you can see that they are almost forming like a dermal papillary epidermal junction, and some also within the dermis. So when you see this kind of pattern, there is two differential diagnoses. So because you have already gone through a kind of an algorithm in your brain, your differential diagnosis is narrowing down quite a bit. So subepidermal type of neutrophils lining the dermal epidermal junction, you are going to think of linear IgA vesiculobullous disorder, and the other differential diagnosis is going to be bullous lupus. Those are the two differential diagnoses when you see this kind of a was a bullous lupus, then you are going to see a full house. Then you are going to see the linear IgA, you are going to see IgG, IgM, all of it. And in a lupus, which is here, you can see like this is a case of a bullous lupus. The inflammation also tends to be around the hair follicle. So you can see the neutrophilic abscesses, the neutrophilic lining of the dermal epidermal junction. But if you look in the dermis, you are going to see this perifollicular and perivascular infiltrate, and in this one there you see the bluish tinge here basically. So that gives you a clue that you are dealing with bullous lupus. So this is a free resource that we have created. All of you know about another resource. You can then create a login for yourself. So once you create a login for yourself, you will be able to log in here. And when you log in here, you're going to see this free book that we have created. So this is a book for dermatopathology. So this is the entire read. You say I want to read this book. This has been like these are the best like creator was my mentor at MD Anderson, and Dr. Esther and Dr. Bhavan have been like Dr. Esther and Dr. Bhavan have been like spectacular teachers that are coming clinical differential every diagnosis, multiple clinical images and multiple host images. So that is another resource that anybody can use. Thank you very much. Thank you. So I finished for time. Thank you very much.
Thank you, sir, for the wonderful presentation. I think dermatopathology is a challenging field in pathology, and you have covered so well. Thank you very much, sir. Thank you.
You're welcome. Thank you for the opportunity.
Please welcome them with a huge round of applause. Give a huge round of applause to our speaker.
Hi, Dr. How are you? Nice to see you.
सेंटर ले ऊपर सेंटर लेके देखो
Thank you so much, sir. Thank you, ma'am. We request our chairpersons, Dr. Mala Sagar, Dr. Veena Gupta, and Dr. Amrinder Kaur to kindly remain seated as we now begin
Very good morning all. Is it okay to start? Very good morning all. I'd like to thank the organizers for the opportunity to present on this topic today. I just want to confirm, are you able to see my screen?
Yes.
I don't think I can hear you.
Yes, we are seeing.
Okay, perfect. Okay. So history psychosis has been my immunophenotype. Having said that, the absence of empiripolysis does not exclude Rosai-Norton disease. So RDD is characteristically shows positive expression of CD163, S100, OCT2, and cyclin D1. Cyclin D1, just like I attributed earlier, is because of the underlying MAP kinase pathway activation. Underlying MAP kinase pathway activation doesn't always mean we'll find a mutation. There's probably some other alternative working group, and he suspected something else was going on, and he ordered a whole body PET CT given the bilateral knee pain, which showed this bilateral bony osteosclerosis of the knee bones as well as perinephric thickening. On further workup, there was subtle histiocytic infiltrates, which was missed at the time of initial diagnosis, and this histiocytic infiltrate showed BRAF V600 positivity. This is a case of benign-chested disease mimicking IgG4-related disease. Amongst all histiocytic disorders, ECD is one of the most complex disease to make on histopathology. It always requires a mandatory clinical plus radiology plus histopathologic correlation. I want to just emphasize on the histopathologic features. It's usually characterized by this bland appearing foamy histiocyte with or without two-tone type giant cells. When you have BRAF expression, which is present in 50 to 60% of the cases, then you can think about benign-chested disease. But a diagnosis of ECD should be made in conjunction with radiology and other clinical presentation. But in the remaining 30 to 40% of the cases that are BRAF negative, we really do not have a pathognomic marker. But we published a recent study that showed this cyclin D1 expression in over 90% of ECD cases, characterized by this diffuse strong nuclear and weak to intermediate cytoplasmic positivity, which could be a subtle clue on histopathology for us to think about ECD and direct the clinician to actually work it up further with a comprehensive radiologic evaluation. Eventually, we always need next generation sequencing in this for the purposes of treatment, but sometimes for the purposes of diagnosis too. This is case number 4 in a 40-year-old male who presented with multiple skin lesions, and the red arrow indicates the two-tone type giant cells. It has this xanthogranuloma-like morphology. On immunophenotype, showed this diffuse expression of S100, variable expression of cyclin D1, and factor 13A positivity. This is called as a dermal macrophage phenotype, and you have macrophage markers in conjunction with factor 13A expression, which is commonly seen in juvenile xanthogranulomas as well as adult onset xanthogranulomas. The diffuse S100 expression here doesn't mean it's a Rosai-Hoffman disease phenotype, because the morphology here does not fit the classic Rosai-Hoffman morphology per se. In general, xanthogranuloma lesions, up to 30% of the cases can be S100 positive. So this case it belongs to the xanthogranuloma family of histiocytic lesions. Depending upon the age, you can say juvenile xanthogranuloma or adult onset xanthogranuloma. The juvenile is JHG, is the most commonly recognized term, primarily because of its awareness in the pediatric population. But rather than calling JHG in adults, AHG would be a better terminology. But regardless of this, the main key thing to note is that they have extensive overlapping morphologic features with benign-chested disease, so mandatory radiologic correlation is necessary to exclude ECD. This particular case did not have any systemic involvement and just showed a FLT3 fusion, and interestingly, the patient did show a remarkable response to sorafenib therapy, as you can see here in this PET, near complete response at 6 months of treatment. Really emphasizes the significance of NGS in cases, especially in adult xanthogranulomatous lesions. When the lesions are persistent and they don't go away, always think about what can be the genetics that one can target in order for the patient to show complete response. And talking about the other end of C group of histiocytosis, like I attributed earlier, not all of the lesions in the C, that is cutaneous group, are histiocytic neoplasms. There is a lot of benign and just inflammatory histiocytosis in the cutaneous group. The list is so big, but the key thing to note is that they typically lack the immunophenotypic let's note, from a true neoplastic Langerhans cell histiocytosis, which is characterized by the sinusoidal-based expansion by the Langerhans cells. Now, like I said earlier, Langerhans is mandatory for a diagnosis of LCH because this entity here is Langerhans negative, and if it's CD1A positive, Langerhans negative, it's a case of indeterminate dendritic cell histiocytosis. Oftentimes, it harbors the MAP kinase pathway mutation similar to other histiocytic disorders, but it can have a slightly different prognosis depending upon the extent of involvement and slightly different biological cause, but we still are learning more about this particular entity. Case number 6, this is a 60-year-old female with a skin lesion on the neck, and as you can see, this kind of streaks of epithelioid cells, which were interpreted as initially positive for CD68 and CD163, negative for all other markers for carcinoma, sarcoma, melanoma, and lymphoma, and initial diagnosis was histiocytic sarcoma. However, on a second opinion, when you go at higher power view, the PU.1 is a macrophage marker as well. It also stains small B cells. You can see this PU1 marker does not stain this epithelioid cells, rather stains the admixed reactive histiocytes. This is a case of pleomorphic dermal sarcoma, which was misdiagnosed as histiocytic sarcoma. Many tumors can show cyclin D1 expression through a variety of pathways. You can see cyclin D1 in melanoma, other epithelial tumors as well as sarcomas. So you have to interpret the cells in context of the multiple histiocytic markers prior to classifying them in the histiocytic lineage. So in terms of diagnosing malignant histiocytic neoplasms, it's very important to keep this in the differential when you're evaluating the big four: carcinoma, sarcoma, melanoma as lymphomas with anaplastic morphology. In the interest of the time, I'm not going to go into the details of this. There is a paper that we published, and that has this characterization of the phenotypic spectrum of the different subtypes. The key thing is to note is that these MHNs needs to be kept in the differential before you classify an entity as wholly differentiated malignant neoplasms. And I want to give a brief note on this PD-L1 expression in malignant histiocytic neoplasms. We found that the PD-L1 expressions in MHNs, if they're present in over 30% of the tumor cells, have an excellent response to immunotherapy. We really don't have a good treatment pathway for malignant histiocytic neoplasms, unlike other histiocytic processes. So this is something like a work in progress, but when you have an MHN case, always do a PD-L1 so that will help the clinician to consider immunotherapy in future. This particular case, interestingly, had a MET exon 14 skipping mutation, but it was unresponsive to a MET inhibitor, but interestingly showed a remarkable response to pembrolizumab within 42 days of treatment. Finally, the last portion of the slides, I know the time is almost up. I'm going to try to wrap it up quickly. So when you have a histiocytic infiltrate that is mass forming, if there is a clinical, radiology, or pathology suspicion, any pathologist can suspect it. It's really important to evaluate by a pathologist who has experience with histiocytic disorders. And when you evaluate it, it's generally recommended to do at least a panel of histiocytic and classical dendritic cell markers. And this is a summary slide that really details the immunophenotypic characteristics
a very difficult one. So I hope you have made this topic really easy for us. Thank you so much, ma'am. So with this, you're welcome, ma'am. So with this, I would like to request our team from organizing committee, Dr. Parveen, Dr. KD, to kindly grace the dais, to facilitate our chairperson and speaker, and Dr. Jasprit Singh.
Ma'am, we have a small token of appreciation for you. We'll hand it over to one of your colleagues. Please allow us to do that. Dr. Thala, please come to the stage and please accept the appreciation on behalf of Dr. Shwarya. A huge round of applause for our speaker, please. Now to honor the chairpersons. A huge round of applause for them, please.
A huge round of applause, everyone. Yes, ma'am, sure, ma'am. Hi, Aishwarya, can you hear me?
Yes, I
This
can.
was a fantastic talk, especially the case of Hodgkin's that you showed, how difficult that could be with the eosinophils in the background. I trained in hematopathology in late 1990s at MD Anderson Cancer Center in Bangalore. So and I think I was actually at UAB for 12 years as a tenure fellow.
Oh, that's fantastic. That's wonderful.
And that's what I wanted to tell you, that you did fantastic. Great presentation. When I knew you are from UAB, I was not expecting that I would take this plaque on behalf of you, but I'm so proud of you, and I'm honored that as a UAB faculty, I'm ever UAB faculty. I'm
pick it up. Pick it up. Pick it up. आगे
Dr. KD sir, they can token side the steps like you. Or not ahead of time.
pick it up. Yes, ready?
Dr. Gilsam,
Yes, ready?
A huge round of applause for our chief guest, our health minister, Dr. Pathology Singh. We request all the dignitaries and delegates to kindly be seated as we begin the formal inauguration event. On behalf of the organizing team, I formally invite Dr. Jasprit Singh, Professor Pathology, Government Medical College, Amritsar, to master the ceremonies for the inauguration ceremony. Sir, you are kindly requested to take the charge and initiate the process.
so first of all, we welcome our worthy Cabinet Minister Dr. Gurveer Singh ji. Welcome sir to our conference and dignitaries, DRV sir, JDM sir, and all the delegates. So welcome you all to the 31st IPNA ICB 2026 in the Holy City of Amritsar at Government Medical College Amritsar. That is one of the oldest and the most reputed medical institutes of North India. On behalf of the organizing committee, I extend a welcome to all the distinguished delegates present here. To formally commence the inaugural proceedings of this academic conference, it is my proud privilege to invite our revered dignitaries to raise the flag. First of all, I would welcome Dr. Gurveer Singh, our minister, to kindly come on the stage. Dr. Parveen, our organizing chairperson, Dr. Vijay, our kindly. also welcome on the dais Dr. Avinash, our DRME sir. So Dr. KD and Dr. Karanjeet, kindly sir, please accompany them on the stage, sir. I invite our joint DRME madam, Dr. Pinder Gaur, to kindly come on the stage. Dr. Karanjeet Gill and Dr. Atri sir, please sir, accompany us. I also invite Colonel Dr. Deepak Mishra, Dean ICP, to kindly grace the stage, sir. Dr. Ratambra Nada, ICP Secretary, madam please. Dr. Ranganathan, Coordinator Rajna. Dr. P.S. Bajpai, PMC member, kindly sir, please grace the stage. Our working minister, sir, Dr. Kulveer Singh Ji. He is an ophthalmologist of repute. Yourself, sir, I am sure you will agree that such gatherings contribute a lot to collective wisdom and innovative skills and techniques in medical sciences. So I now call upon the stage for the auspicious lamp lighting ceremony. Thank you, sir.
Gagana?
I also invite Dr. Vikas Mehra to kindly come on the stage. Vikas Mehra. I also invite on stage Dr. Sindarjeet Singh Bajaj, our civil surgeon of Amritsar. So it's very nice to see that Dr. Vinay Kumar is also watching the proceeding. Thank you, sir. Thank you so much, sir. So to start with the proceedings, I invite our organizing chairperson, Dr. Parveen Bhakar, to have a welcome address.
A very good morning to all of you. Our Honorable Chief Guest, worthy Health Minister of Punjab, Dr. Balbir Singh Ji, respected DRME, Dr. Amish Kumar Ji, Joint Director, Dr. Gobinder Kaur, Vice Principal Sir, Dr. J.P. Atri, Medical Superintendent, Dr. Karanjit Singh, Dean ICP, Colonel Dr. D.K. Mishra, ICP Secretary, Dr. Ratambara, Coordinator, APNA, Dr. Ranganathan, PMC members, Dr. B.S. Bajwa, Convener, Dr. Vijay, Director, PIMS and Chief Advisor, Dr. K.D., Dr. Karanjit Gill, Professor and Head Pathology, SGRD, other dignitaries on stage, our distinguished speakers from USA and India, dear faculty members, and delegates from different parts of India and overseas. On behalf of the organizing committee, it is my profound honor to welcome you all to the 31st APNA ICP 2026 International Pathology Conference here in Amritsar. I extend heartfelt gratitude to our chief guest, the Honorable Health Minister, Dr. Balbir Singh Ji, for gracing this occasion. His visionary health programs in Punjab, ranging from strengthening primary health care to expanding access to advanced medical services, have truly uplifted the well-being of residents of Punjab. We also acknowledge with deep appreciation the Honorable Chief Minister of Punjab, Sardar Bhagwant Singh Manji, whose commitment to health-related projects has transformed infrastructure and brought innovative initiatives that benefit communities across the state. I wish to place on record our sincere admiration for the respected DRME, Dr. Amish Kumar, whose tireless efforts in the development of medical colleges have expanded opportunities for medical education and training, thereby strengthening the backbone of healthcare delivery in Punjab. We extend our heartfelt appreciation to Dean, Indian College of Pathology, Colonel Dr. D.K. Mishra, whose guidance and vision have ensured that ICP remains a pillar of academic strength and professional growth. Equally, we acknowledge the Association of Indian Pathologists in North America, whose vision and commitment have sustained this remarkable tradition of collaboration. Under the dynamic leadership of President Dr. Megha Joshi, Coordinator Dr. Ranganathan, APNA has tirelessly worked
बहुत ही सत्कारयोग आज की इस कॉन्फ्रेंस के मुख्य मेहमान डॉक्टर बलबीर सिंह जी, हेल्थ मिनिस्टर पंजाब, स्टेज पे बैठी बहुत डिग्नेटरीज, एमिनेंट स्पीकर्स, डेलीगेट्स। मैं सब तो पहला ऑर्गेनाइजिंग कमेटी चेयरपर्सन सैकटरी उन्होंने बधाई दिंदा हाँ कि इन्होंने अज GMC विखे इस इंटरनेशनल कॉन्फ्रेंस का आयोजन किया है और साढ़े वास्ते बहुत ही माण की ये गल है कि अज इस कॉन्फ्रेंस से साढ़े मानयोग सेहत मंत्री जी साढ़े कोल ने उन्होंने अपने रुझेवे विचों टाइम कढ़िया। सो मैनू दसदे भी बहुत खुशी हो रही है कि डॉक्टर बलबीर सिंह जी मेरे मेडिकल कॉलेज में सीनियर आप इकट्ठे सीगा और इन्होंने मैनू हाथ फड़ के सर्जरी सिखाई। आई वॉज बिगिनर तो मैनू याद आ ये दिन। सो मैनू बड़ा मान महसूस होता है कि मेरे गुरु जी है। सो मैं बहुता टाइम ना लवां क्योंकि ऑलरेडी साडे बहुत रुझेवे ने। तो इस कॉन्फ्रेंस के जोड़े PMC ने 12 क्रेडिट आवर्स जो अलॉट किए हैं तो हाल तक डेलीगेट्स और मैं एक बार फिर तय दिल तो ऑर्गेनाइजिंग कमेटी चेयरपर्सन सारे का धन्यवादी हाँ और खास तौर पर जो साडे डेलीगेट्स अमेरिका तो जो बाहर की कंट्री तो आए हैं उन्होंने भी किया है कहना धन्यवाद।
Thank you, sir, for this report, and thanks for granting 12 CM credit hours to participate. Thank you, sir. So I would like to invite Dr. Ranganathan, Patna Coordinator, to kindly say a few words, sir.
Good morning, everyone. Honorable Chief Guest and all the dignitaries on the podium. Thank you for taking so much pains and so much of organization to try and put together this wonderful CME International Pathology Conference. My job was much smaller. I just had to find the necessary foreign delegates who could come and spare some time and come attend this conference and partake in the knowledge. But you had the bigger task in hand, trying to put together everything and making sure all arrangements are made at your end. So again, thank you all for doing a wonderful job. The mission of IPNA has always been to spread knowledge in India and the alma mater. Most of the people here are alumni from different institutions in India, and they love the opportunity to come back every year to educate all the pathologists, colleagues, the trainees, the postgraduates, the medical students, whoever participates in these conferences, and impart whatever knowledge they can as a broadening of scientific discoveries and ideas, basically, and create new collaborations and give opportunities to new students if they are ever interested in participating in advancing their careers in the United States. So I think this is a great opportunity for all of us to get together and share our experiences, I would say, and also carry the science forward as well as give opportunities to the new learning, new people who are coming into the career of pathology. So I think that I will not take much more time. I think this has been wonderfully arranged, and I want to thank everyone again. And I'm thrilled to be over here, and I look forward to participating with other places in the future. Thank you all.
Thank you, sir. We have listened to you for the last 2 days with your vast experience. Thank you so much. So I would like to invite Colonel Dr. D.K. Mishra, Dean ICP, to say a few words.
Very good morning to this august audience. At the outset, I would like to thank the chief guest for the morning, His Excellency Dr. Balveer Singh, the Health Minister of Punjab, who have graced this occasion, and all the dignitaries on the dais, and the dignitaries, the faculty, the delegates of the dais. Indian College of Pathology is an academic arm of the Indian Association of Pathologists and Microbiologists, and this is the 31st ICP Joint International CMA in Pathology that happens every February of the year in some part of the country, and this time it is this wonderful city of Amritsar which is hosting it. The ambience, the academic fervor in the Government Medical College Amritsar has been excellent. We have been hearing to multiple speakers from India and from the United States for the last one day, and again we'll be listening to them for today and tomorrow. As you know that the theme of Indian College of Pathology is to propagate the frontiers of pathology. As you know that the pathology is at the crossroads, multiple subspecialties are growing, and everybody is subspecializing in some area or the other. The chief guest is an ophthalmologist, so I'm sure he is aware about ophthalmic pathology, and many people are now specializing in ophthalmic pathology. And I, being a pathologist and a molecular pathologist, I look at the retinoblastoma gene. I think you must be familiar with. So the areas that are coming up and are gaining ground is molecular pathology. Now we have added artificial intelligence in pathology and digital pathology. So these are all emerging branches of pathology. Right now in Delhi we are having the global AI meet, and I'm sure people are talking about the application of artificial intelligence, machine learning, deep learning in the field of pathology. So as part of our PDCC courses, postdoctoral certificate courses, we have included AI in pathology as one of the PDCC programs in addition to digital pathology. And molecular pathology has already been there for quite some years, and now these are the two new additions to the PDCC courses. Every year we do this conference, and I'm very happy that large number of delegates have registered for this conference in Amritsar. The Northwestern chapter of pathology, the Punjab chapter of pathology, has been remarkably doing well in organizing scientific meetings at different places in the northwest part of India. Amritsar has the legacy of being one of the very old medical colleges of the country, and it has produced large number of brilliant medical faculty who have spread all over the country to develop medical science in various institutions. I will not stand in your way for others to speak, so I was asked to be brief. And before I leave the podium, I would like to profusely thank the organizers led by Professor Parveet Baka, Dr. Vijay Bodal, the Professor Gill, Professor Jaspreet, and all of them who have made it possible. I may not have mentioned everyone's name, but I mean from the core of my heart that everybody who has worked for the organization of this conference, I thank them from the bottom of my heart, and thank you very much. And as we finish this conference in another day's time, the next conference also we would like to announce that the 32nd conference is going to be in Jipmer, Pondicherry, again in February 2027. So there's no representative from Jipmer Pondicherry here because they are having a neuropathology conference same day as in Jipmer. So on behalf of them, I welcome you all to the next edition of the conference in February 27. With that, I thank you very much. Thank you. Jai Hind.
True to his word, Dr. Mishra is known for his academic and research skills. Thank you, sir. Now I call upon our respected DRP sir, Dr. Niji, sir, kindly come on the stage and speak a few words, sir.
Dr. Balveer Singh Ji, Honorable Cabinet Minister for Medical Education and Research and Health and Family Welfare, dignitaries on the stage and off the stage, organizers and colleagues from APNA and ICP, dear faculty, residents and distinguished guests, delegates, it's a great honor to address you today at AIPNA ICP 2026 hosted by the esteemed Department of Pathology at Government Medical College Amritsar. Thank you to the organizing team for this remarkable gathering in the historic city of Amritsar under the inspiring theme Advancing Pathology from Microscopic Insights to Global Impact. Over these days, we celebrate the journey of our field from the fundamental microscope to tools that influence health worldwide. Pathology began with meticulous cellular observations, Virtual's legacy that disease resides in tissues. That human expertise in interpreting slides remains essential, even as we integrate immunohistochemistry, NGS, liquid biopsies, digital whole slide imaging, and AI. These advancements transform local diagnosis into global knowledge. Telepathology connects experts across borders. AI enhances consistency and speed. Through AIPNA ICP collaboration, we bridge North America and India, sharing subspecialty insights in GI and hepatobiliary, cytology, breast and gynae, molecular pathology, digital diagnostics, and more. The theme captures this evolution perfectly. Microscopic insights fueling global impact in fighting cancer disparities, infectious diseases, and non-communicable burdens, especially in resource-limited settings. To accelerate progress, let us focus on three priorities. Number one, integrate technology thoughtfully. Use digital tools and AI to augment, not replace our expertise. Train the next generation ethically. Number two, build capacity and through education. Expand fellowships, telemonitoring, slide seminars and workshops to democratize subspecialty knowledge. Third, drive translational research. Address local needs, for example, Indian cancer profiles, regional infections, while contributing to global databases and policies. Every accurate diagnosis, shared case, or mentored resident creates ripples. A biopsy interpreted here today can save lives far beyond Amritsar tomorrow. As we engage in lectures, interactive sessions, case discussions, and networking over the coming days, let us recommit. Keep the microscope as our anchor, but extend our vision globally. Together through AIPNA, ICP, and events like this, we advance pathology for equitable, life-changing impact. Thank you for this privilege. I wish you an inspiring, collaborative conference. Jai Hind.
Thank you, sir. bringing the latest equipment in our department. Thank you, sir. So now it's a time to honor the distinguished luminaries, and the first on the list is our worthy Dr. Vinay, who is just listening to us from Chicago. So I would like to invite Dr. Niraj Jhala and Dr. Darshan Jhala to come on the stage and accept the award on his behalf. So before that, I would like to speak a few words about Dr. Vinay. Dr. Vinay is an authority on the cellular and molecular biology of natural killer cells. He has been a leader in understanding the origin and differentiation of these cells and their role in the rejection of transplant. So, and students, as everybody present in this hall, as medical students, everybody has read his book. The whole world has read his book. So the author of Robbins and Pathological Basis of Disease and Robbins Basic Pathology, the two most I will request Dr. Vinay Kumar, our lovely teacher, to speak a few words. Over to you, sir.
मैं तो सुनने वास्ते आया सी बोलने वास्ते नहीं आया सी फिर भी इस तरह मैं कल क्या सी कि मेरे एक दिल का टुकड़ा ऐसे रह गया कि तुसी ध्यान ना रखना कि किसी में लेने वास्ते आ जाना शुरुआत जड़ी सी मेरी बुनियाद जड़ी सी मेरी जड़ जड़ी सी वो अमृतसर डॉक्टर एन एल चिटकारा उस वक्त एचओडी होते थे डॉक्टर तुलसीदास चोर प्रोफेसर होते थे उन्होंने मैंने इन्ना इंस्पायर किया कि मैं बस उस तो बाद रस्ते ते लग गया इतों मैं एम्स गया फिर अमेरिका गया मैं थानों एक बड़ी खुशी नाल दसना चाहना वा कि हुण साडी किताब जिहड़ी साडी है इहदे विच एक असीं इंडियन ऑथर ऐड कीता है अभिजीत दास दिल्ली च रहिंदे ने ते दोवें बेसिक पैथोलॉजी ते पैथोलॉजी बेस ऑफ डिजीज दोवां दे विच अभिजीत दास ਜਿਹੜੇ ਦਿੱਲੀ ਰਹਿੰਦੇ ਨੇ ਉਹ ਸਾਡੇ ਨਾਲ ਕਹਿੰਦੇ ਨੇ ਕੋ-ਆਥਰ ਬਣ ਗਏ ਨੇ ਇਸ ਗੱਲ ਦੀ ਮੈਨੂੰ ਬਹੁਤ ਖੁਸ਼ੀ ਬਹੁਤ ਖੁਸ਼ੀ ਹੋਈ ਕਿ ਅਮਰੀਕਾ 'ਚ ਛਪਣ ਵਾਲੀ ਕਿਤਾਬ ਜਿਸ ਦੀ ਤਾਰੀਫ ਸੁਣ ਚੁੱਕੇ ਹੋ ਉਹਦੇ ਵਿੱਚ ਇੱਕ ਸਾਡਾ ਹਿੰਦੁਸਤਾਨੀ ਪੈਥੋਲॉजी ਆ ਗਈ ਮੈਨੂੰ ਇਸ ਗੱਲ ਦੀ ਬਹੁਤ ਖੁਸ਼ੀ बहुत खुशी कोशिश करेंगे कि कभी थोड़ी मुलाकात हो जाए बाकी और बहुत सारी गल्लां ਡਾਕਟਰ ਵੀਰ ਸਿੰਘ ਨੂੰ ਮੈਂ ਕਹਿਣਾ ਚਾਹੁੰਦਾ ਡਾਕਟਰ ਸਾਹਿਬ ਤੁਸੀਂ ਅੰਮ੍ਰਿਤਸਰ ਨੂੰ ਵਧਾਉਂਦੇ ਜਾਓ ਹੋਰ ਉੱਚਾ ਕਰੋ ਹੋਰ ਉੱਚਾ
Thank you so much, sir. Thank you, sir. It was really, really listening to you, sir. Thank you, sir. Goodbye, sir. Goodbye, sir, and wish you good health, sir. Thank you, sir.
Thank you.
So I would like to invite our previous HODs. So I'm Dr. Amarjeet Singh sitting here, sir. Kindly, sir, come on the stage, sir, please. Dr. Manjeet Singh Bal, sir, kindly come on the stage, sir. Dr. Vijay Mehra. Dr. Suri. Wait. So, I also touch upon our worthy minister, sir, to honor our DRB, sir. Our worthy MS, Dr. Pathology Singh. Dr. J.P. Atri, our Vice Principal, sir. Dr. J.P. Atri. उसके बाद डॉक्टर बाजवा, BMC member. Dr. Ritandra. Dr. Ranganathan. Dr. Ranganathan. Dr. D.K. Mishra. Dr. Parmeet, our chairperson. Dr. K.D. Singh, Director, PIMS. Dr. Vijay Bodal, Convener. Ranveer Singh Gill, Chief Advisor.
Dr. Jasprit Singh.
Dr. Mandeep Randhawa.
Dr. Navjot Kaur. On behalf of Dr. Navjot Kaur, Dr. Nadeem will have the floor. Dr. Poonam. Dr. Vinay Sharma. These are all part of organizing committee. Dr. Aman Gupta, PMC member. Dr. Vikas Mehta, who is already on the desk. Dr. Preeti Pata. Dr. Aman Gupta, PMC member. ਉਸ ਤੋਂ ਬਾਅਦ ਡਾਕਟਰ ਸਤਿੰਦਰਜੀਤ ਸਿੰਘ ਬਜਾਜ, ਸਿਵਲ ਸਰਜਨ ਅੰਮ੍ਰਿਤਸਰ। ਡਾਕਟਰ ਅਨਿਲ ਜੋਤਵਾਨੀ, say a few words, sir. Thank you, sir. ਸਾਰਿਆਂ ਨੂੰ ਪਿਆਰ ਭਰੀ ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਔਰ ਮੇਰੇ ਵੱਡੇ ਵੀਰ ਜਿਹੜੇ ਐਕਚੁਅਲੀ ਸ਼ਿਕਾਗੋ ਤੋਂ USA ਤੋਂ ਸਾਡੇ ਨਾਲ ਹੈ ਡਾਕਟਰ ਵਿਨੇ ਮੁਕਲਮਕੜੀ ਡਾਕਟਰ ਸਾਹਿਬ ਤੁਹਾਡੀ ਜਿੰਨੀ ਵੀ ਤੁਸੀਂ ਥੋੜੀ ਜਿਹੀ ਗੱਲ ਕੀਤੀ ਹੈ ਉਹ ਸੁਣ ਕੇ ਨਾ ਜੀ ਮਤਲਬ ਜਿਵੇਂ ਦਿਲ ਨੂੰ ਛੂਹਣ ਵਾਲੀਆਂ ਗੱਲਾਂ ਕੀਤੀਆਂ ਤੁਸੀਂ ਤੇ ਸਾਨੂੰ ਬੜਾ ਮਾਣ ਹੈ ਤੁਹਾਡੇ ਤੇ ਡਾਕਟਰ ਵਿਨੇ ਕਿ ਤੁਸੀਂ ਇਸੇ ਕਾਲਜ ਤੋਂ ਪੜ੍ਹ ਕੇ ਔਰ ਇਸੇ ਹੋਸਟਲ 'ਚ ਰਹਿੰਦੇ ਹੋਏ ਤੁਸੀਂ ਇੱਕ ਗਲੋਬਲ ਸਟੇਜ ਤੇ ਤੁਸੀਂ ਆਪਣੇ ਨਾਲ ਤੁਸੀਂ ਇਸ ਕਾਲਜ ਦਾ ਪੰਜਾਬ ਦਾ ਔਰ ਦੇਸ਼ ਦਾ ਨਾਮ ਉੱਚਾ ਕੀਤਾ ਵੀ ਆਰ ਪ੍ਰਾਊਡ ਆਫ ਯੂ ਐਂਡ ਕੀਪ ਗੋਇੰਗ ਸਰ ਬਹੁਤ ਸਾਰੀਆਂ ਜਨਰੇਸ਼ਨ ਤੁਹਾਡੀ ਕਿਤਾਬ ਪੜ੍ਹ ਕੇ ਪੈਥੋਲੋਜੀ ਦੀ ਡਾਕਟਰ ਬਣੀਆਂ ਔਰ ਉਸ ਤੋਂ ਬਾਅਦ ਬਹੁਤ ਸਾਰੇ ਲੋਕ ਸਪੈਸ਼ਲਿਸਟ ਬਣੇ ਆ ਔਰ ਇਹ ਸ਼ਹਿਰ ਬਾਰੇ ਜਿੰਨੇ ਵੀ ਸਾਡੇ ਆਲ ਦਾ ਡਿਕਟਰੀਜ਼ ਅੰਮ੍ਰਿਤਸਰ ਦਿਸ ਇਜ਼ ਸਿਟੀ ਆਫ ਡਾਕਟਰ ਇਹਨੂੰ ਜੋ ਸਿੱਖ ਗੁਰੂਜ਼ ਹੈ ਔਰ ਸਾਡਾ ਜਿਹੜਾ ਸਿੱਖਾਂ ਦਾ ਸਭ ਤੋਂ ਵੱਡਾ ਜਿਹੜਾ ਪਿਲਗ੍ਰਿਮੇਜ ਸੈਂਟਰ ਹੈ ਉਹ ਵੀ ਇੱਥੇ ਹੈ ਔਰ ਇੱਥੇ ਸਾਰੀ ਦੁਨੀਆ ਤੋਂ ਔਰ ਸਾਰੀਆਂ ਸਟੇਟਸ ਤੋਂ ਲੋਕ ਆਉਂਦੇ ਆ ਔਰ ਜਿਸ ਤਰ੍ਹਾਂ ਤੁਸੀਂ ਜਾਣਦੇ ਹੋ ਕਿ ਸਿੱਖਾਂ ਦੇ ਗੁਰਦੁਆਰੇ ਵਿੱਚ 4 ਦਰਵਾਜ਼ੇ ਹੁੰਦੇ ਆ ਕਿ ਸਾਰੇ ਪਾਸਿਆਂ ਤੋਂ ਕੋਈ ਕਿਸੇ ਵੀ ਧਰਮ ਦਾ ਕਿਸੇ ਵੀ ਜਾਤ ਦੇ ਲੋਕ ਕੋਈ ਰਿਸਟ੍ਰਿਕਸ਼ਨ ਨਹੀਂ ਹੈ ਅਨਲਾਈਕ ਅਦਰ ਰਿਲੀਜਨਸ ਔਰ ਇਹਦੇ ਨਾਲ ਡਾਕਟਰ ਵਿਨੇ ਤੁਸੀਂ ਜ਼ਿਕਰ ਕੀਤਾ ਡਾਕਟਰ ਤੁਲਸੀਦਾਸ ਦਾ ਜਦੋਂ ਦੇਸ਼ ਆਜ਼ਾਦ ਹੋਇਆ ਤਾਂ ਉਦੋਂ ਪੰਡਿਤ ਜਵਾਹਰ ਲਾਲ ਨਹਿਰੂ ਨੇ ਸੋਚਿਆ ਕਿ ਅਸੀਂ ਜੇ ਅੱਗੇ ਵਧਣਾ ਤਾਂ ਵੀ ਸ਼ੁੱਡ ਹੈਵ ਇੰਡੀਅਨ ਇੰਸਟੀਚਿਊਟ ਆਫ ਮੈਨੇਜਮੈਂਟ ਟੈਕਨੋਲੋਜੀ ਐਂਡ ਮੈਡੀਕਲ ਇੰਸਟੀਚਿਊਟਸ ਸੋ ਦੂਜੇ ਪਾਸੇ ਜਿਹੜਾ ਦੇਸ਼ ਸੀਗਾ ਮਤਲਬ ਫੂਡ ਗ੍ਰੇਨ ਦਾ ਬਹੁਤ ਜ਼ਿਆਦਾ ਡੈਫੀਸ਼ੀਟ ਸੀਗਾ ਅਕਾਲ ਕਰਦੇ ਹੁੰਦੇ ਸੀਗੇ ਆਈ ਥਿੰਕ ਡਾਕਟਰ ਵਿਨੇ ਹੀ ਮਾਈ ਲੀਡਰ ਬ੍ਰਦਰ ਸੋ ਹੀ ਬੀਅਰ ਵਿਦ ਮੀ ਕਿ ਬੰਗਾਲ ਦੇ ਵਿੱਚ ਉੜੀਸਾ ਦੇ ਵਿੱਚ ਲੋਕ ਭੁੱਖ ਨਾਲ ਮਰਦੇ ਹੁੰਦੇ ਸੀ ਹਜ਼ਾਰਾਂ ਦੀ ਗਿਣਤੀ ਦੇ ਵਿੱਚ ਤੇ ਉਹਨਾਂ ਨੇ ਕਿਹਾ ਕਿ ਆਪਾਂ ਜਿਹੜਾ ਸਭ ਤੋਂ ਪਹਿਲੀ ਗੱਲ ਹੈ ਕਿ ਸਾਡੇ ਕੋਲ ਖਾਣ ਲਈ ਖਾਣਾ ਹੋਣਾ ਚਾਹੀਦਾ ਤੇ ਆਪਾਂ ਕੀ ਕਰੀਏ ਉਹਨਾਂ ਨੇ ਕਿਹਾ ਜੀ ਇਹ ਪੰਜਾਬ ਕੈਨ ਡੂ ਇਟ ਫਿਰ ਉਹ ਪੰਜਾਬ ਵਿੱਚ ਆਏ ਗ੍ਰੀਨ ਰੈਵੋਲੂਸ਼ਨ ਹੋਈ ਇਟਸ ਅ ਲੌਂਗ ਸਟੋਰੀ ਆਈ ਵਿਲ ਨਾਟ ਗੋ ਇਨਟੂ ਦਾ ਡਿਟੇਲਸ ਬਟ ਵੀ ਬਿਕੇਮ ਏ ਫੂਡ ਸਰਪਲਸ ਸਟੇਟ ਵੈਰੀ ਸਿਕਿਉਰ ਸਟੇਟ ਉਸ ਤੋਂ ਬਾਅਦ ਇਹ ਸੀਗਾ ਕਿ ਆਪਾਂ ਮੈਡੀਕਲ ਕਾਲਜ ਬਣਾਉਣੇ ਆ ਆਈ ਰਿਮੈਂਬਰ ਕਿ PGI ਆਲ ਇੰਡੀਆ ਇੰਸਟੀਚਿਊਟ ਮੈਡੀਕਲ ਸਾਇੰਸਿਸ ਯੂ ਨੀਡਡ ਇੰਸਟੀਚਿਊਟ ਬਿਲਡਰਸ ਤੇ ਉਸ ਵੇਲੇ ਫਿਰ ਪੰਡਿਤ ਜਵਾਹਰ ਲਾਲ ਨਹਿਰੂ ਨੇ ਅੰਮ੍ਰਿਤਸਰ ਆਏ ਡਾਕਟਰ ਤੁਲਸੀਦਾਸ ਹੀ ਇਜ਼ ਦਾ ਫਾਊਂਡਰ ਆਫ PGI ਸਿਮਿਲਰਲੀ ਏਮਸ ਵਾਸਤੇ ਜਦੋਂ ਵੀ ਕਿਤੇ ਕੋਈ ਮੈਡੀਕਲ ਇੰਸਟੀਚਿਊਟ ਹੁੰਦੀ ਸੀ ਤੇ ਉਹ ਕਹਿੰਦੇ ਸੀ ਕਿ ਇੱਕ ਡਾਕਟਰ ਅੰਮ੍ਰਿਤਸਰ ਤੋਂ ਲਿਆਓ ਜਿਹੜਾ ਡਾਇਰੈਕਟਰ ਪ੍ਰਿੰਸੀਪਲ ਅੰਮ੍ਰਿਤਸਰ ਤੋਂ ਲਿਆਓ ਬਾਕੀ ਇੰਸਟੀਚਿਊਟ ਉਹ ਬਣਾ ਦੇਣਗੇ ਸੋ ਦੈਟ ਇਜ਼ ਦ ਰੈਪੂਟੇਸ਼ਨ ਆਫ ਅੰਮ੍ਰਿਤਸਰ ਡਾਕਟਰ ਵਿਨੇ ਇਹਨਾਂ ਨੇ ਰੈਕੋਗਨੀਸ਼ਨ ਲਈ ਹੈ ਔਰ ਇਸੇ ਤਰ੍ਹਾਂ ਮੈਂ ਕਹੂੰਗਾ ਕਿ ਡਾਕਟਰ ਨਿਰੰਕਾਰੀ ਵੈਰੀ ਐਮੀਨੈਂਟ ਆਈ ਸਕਦੇ ਉਹ ਵੀ ਇਹਨਾਂ ਦੀ ਸੀ ਇੱਥੇ ਡਾਕਟਰ ਆਈ ਰਿਮੈਂਬਰ ਡਾਕਟਰ ਕੌਮ ਡਾਕਟਰ ਹਰਦਾਸ ਸਿੰਘ ਦੇ ਵਰ ਦਾ ਜੁਆਇਨਸ ਆਫ ਦੇਅਰ ਫੀਲਡਸ ਬਹੁਤ ਸਾਰੇ ਦੂਰੋਂ ਲੋਕ ਉਹਨਾਂ ਕੋਲੇ ਦੇ ਕੰਮ ਯੂਜ਼ ਟੂ ਕਮ ਟੂ ਦੈਮ ਫॉर ਸਰਜਰੀਜ਼ ਫॉर ਮੈਡੀਕਲ ਕੇਅਰ ਐਂਡ ਡਾਕਟਰ ਦਲਜੀਤ ਸਿੰਘ ਹੀ ਵਾਜ਼ ਏ ਪਾਇਨੀਅਰ ਉਹਨਾਂ ਨੇ ਜਿਹੜਾ ਇੰਟਰਾਓਕੂਲਰ ਲੈਂਸ ਉਹਦੇ ਵਿੱਚ ਉਹਨਾਂ ਦਾ ਵਰਲਡ ਕਲਾਸ ਕੰਮ ਸੀਗਾ ਔਰ ਪੂਰੀ ਦੁਨੀਆ ਦੇ ਵਿੱਚੋਂ ਜਿਹੜੇ ਲੋਕ ਸੀਗੇ ਉਹ ਉਹਨਾਂ ਕੋਲੇ ਕੰਮ ਸਿੱਖਣ ਆਉਂਦੇ ਸੀਗੇ ਦੇਖਣ ਆਉਂਦੇ ਸੀਗੇ ਕਿ ਡਾਕਟਰ ਦਲਜੀਤ ਸਿੰਘ he was I would say a very innovative person so similarly Dr. Rajveer Singh north of Delhi ਸਾਡੇ ਕੋਲੇ retina surgeon ਕੋਈ ਨਹੀਂ ਹੁੰਦਾ ਸੀਗਾ he was the only one so this city was also known as Mecca of ophthalmology so ਬੜੀ ਇੱਕ ਮਾਣਮੱਤੀ ਪੋਜੀਸ਼ਨ ਹੈ ਇਸ ਮੈਡੀਕਲ ਕਾਲਜ ਦੀ ਇਹਨਾਂ ਨੇ ਬਹੁਤ ਸਾਰੀਆਂ ਇੰਸਟੀਚਿਊਟਸ ਜਿਹੜੀਆਂ ਹੈਗੀਆਂ ਡਿਵੈਲਪ ਕੀਤੀਆਂ ਇਨਕਲੂਡਿੰਗ PGI ਏਮਸ ਐਂਡ ਸੋ ਮੈਨੀ ਅਦਰਸ ਔਰ ਇਹਨਾਂ ਨੇ ਇੰਟਰਨੈਸ਼ਨਲ ਲੈਵਲ ਦੇ ਉੱਤੇ ਵੀ ਔਰ ਤੁਹਾਡੀ ਜਿਹੜੀ ਬੜਾ ਹੀ ਬਿਫਿਟਿੰਗ ਆ ਜਿਹੜੀ ਤੁਹਾਡੀ ਕਾਨਫਰੰਸ ਹੈ ਵਿਚ ਇਜ਼ ਇੰਡੀਅਨ ਕਾਉਂਸਲ ਆਫ ਪੈਥੋਲੋਜੀ Indian College of Pathology and this is American Indian Pathologists of North America. Is that right? So, Association of Indian Pathologists in North America. So again, you see, it's a very, I think, in the present circumstances, when the world is fragmented in the name of so many things. So you unite people because the disease doesn't know any barriers. It doesn't recognize the borders, be it smallpox, be
spread across borders, and why should the knowledge be limited? And this is very befitting that people across continents, they come together, share knowledge, and it benefits our generation next, which I find very few of them are here. So most of the faculty is here. So I mean, in future, I don't know. You see, when we were students, we were hungry to learn more. We will please our seniors, even when we were undergraduates. So if somebody was interested, we were always interested. If there is a conference going on anywhere, so we will never miss it. So I had expected many more students here. So anyway, and in fact, when the conference was organized, we used to work. We used to do all the work as students. You see, and that was this Guru Shish Parampara. Of course, we are talking about now digital pathology. I remember it was way back in '92. Again, another disease which spread across continents, HIV/AIDS hepatitis. So I was very curious. I was working in PCMS in a dispensary. So I was very curious. So you see, I wanted to know how is it coming to Punjab. There were not any injected drug users that time. And I was wondering how come the Punjabis are getting HIV. So I did some research work on that. And for that, I met Professor Shobha Saigal. Dr. Tamra is here. So I think if I remember it correctly, it was immunohistopathology department or something like that. So she spotted me and we did research work which was published in the international journal. So I'm a doctor working in a dispensary and a professor in PJ could work together. So knowledge should have no barriers and it knows no barriers. And that gave me a recognition and it helped the state to formulate policy. So what you do, you see, I look inside the eye, what is happening inside the eye, and you look inside the cell, different cells of the eye, what is happening inside the ganglion cells when the light shines, you see. This knowledge comes from pathologists, and when you are looking at a tissue, there is a patient connected to it, there is a family connected to that, and there is a new society connected to that. So what is happening in COVID, what is happening in so many novel viruses now and so many new diseases, you are the people, when I was student before that, there used to be department of eye and ENT, it was one department. Now we have 10 departments in eye itself, vitro-retina surgery. You see? So the time is progressing. Similarly, I think when Dr. Vinay was student, so it used to be only pathology, there was no microbiology before that time. So now there are many institutes and even among virology and so many other institutes and even you have so many other branches. So we have all the pioneers here, Dr. Mishra, Dr. Tamra, Dr. Ranganathan, and so many other dignitaries in front of me. And I think this is a very good platform to sharing of knowledge. You have a new kid around the block, which is AI. And I think Dr. Mishra mentioned about AI Impact Summit. And India was written by a Chinese AI dog. We have to be careful about many things with AI. I think AI will replace physicians very soon, maybe in the next 2-3 years. But pathologists will be the last one to be replaced. It will take some time. So you are the most relevant doctors, even in the age of AI. So we are proud of you because you see, there is a novel called final diagnosis in a different context. You give the final diagnosis. I have been proven many times. There's no physician, there's no surgeon who has not been proven wrong by the pathologist. So you have the final say. So this is a very, I would say, responsible job as well. So I really thank my dear friend Vijay Bodhar, and you see we work together. Incidentally, I worked in this institute only for a very short period for 3 years. That was 96 to 99. I was senior resident here. I came here to learn. You see, because this was, as I said, it's the mecca of ophthalmology. And I did learn a little bit of vitro-retina, a little bit of more ophthalmology and the latest. And most of the people I learned from are younger than me. That's true. That will always be true. I think you people know you have to work with Gen Z and maybe Gen Alpha also to learn AI from them. They will learn it much faster. So we can, you see, it doesn't know this knowledge. There are no barriers, geographical barriers or even age barriers. So there are many things which I have learned from my students. Of course, we all learn from our patients. So it's again, you see, I congratulate Dr. Pramit Bhagat of this week all the dignitaries on the dais and all of you. And Amritsar is also known for variety of its food. And of course, you must have visited the Golden Temple, the Kana Mandir, and it's the center of the pilgrimage. There is a lot to learn from. The people are very hospitable. People are very known for their, I would say, Punjabis. जो असली पंजाब की जड़ी है ना जो एक्चुअल फ्लेवर है पंजाब का वो थोड़ा अमृतसर च मिलेगा कि लोग बहुत प्यारे मिलापड़े और अपने इंटरप्राइजिंग आल्सो एट द सेम टाइम. Dr. Vinay is the shining example of their entrepreneurial and other clinical, everything hard working, I would say. So, like I think I understand he's in Chicago. You go to Chicago, you go to New Jersey. There are many small mini Amritsars or mini Punjabs in USA itself. Then there is a mini Punjab in Canada and many cities in England, everywhere in Europe. So you will find a small Punjab and they are all doing very well there. So let's work together. And Dr. Vinay, there were two cardiologists. Bernard Lone from USA, I wonder if you know him, and Dr. Eugene Chesel from Russia. That time USSR. It was before 1984. I was a very young doctor. We were given Nobel Prize. There is an association called International Physicians for the Prevention of Nuclear War. That madness has increased. You see, we have a department of war now. So the wars are going on, the wars are raging, and the present leadership, they know how to start a war, they don't know how to stop it. So we have to write a medical prescription for them, for God's sake. Invest in health, invest in education, invest for employment. In another 10 years, we will have 1.2 billion people asking for a job. There will only be less than 400 million jobs. So 2/3 of the youth will be without job. You know what happened in Nepal. So it may not be, you see, you might think it's not important for you. I think the air we breathe, the water we drink, the food we consume, they are all toxins, they are full of cancer, they are full of other diseases. So I think you have to, because I belong to politicians and I belong to you also, I basically belong to you in the last more than 40 years. And very recently I joined politics. So I am, you see, very briefly, sir, you said we are trying to restore the glory of this institute. So now we have neuro, we have cardiac labs, we are introducing all the super specialties. So I have given a free hand to your, I would say, kids. Now it's up to them to come up to the challenge and make this once again the kind of institute where people come searching for doctors from Amritsar. So that is the challenge which we have, and you have my full support. So we are working in primary care where we have Aam Aadmi clinics where they are available in almost every village and every mohalla, where people can go and get medicines for common diseases, hypertension, diabetes, and all of the common diseases, where 47 tests are done free of cost, 107 medicines are given. And now we have a universal health care, where every single family in Punjab will have an insurance cover of 1 million rupees, managed and funded by the government, where the person doesn't have to pay a single penny. So they can have heart bypass surgery or anything, which is managed and paid by the government, and person doesn't have to pay anything. If you meet with an accident, if you have a cancer, if you have any other debilitating disease or you are paralyzed, so what to do? Where do you go? You start, you see, going to relatives, then maybe karza le lo, gahne bech do. You try to get the money first before you go to the doctor. So in the meantime, the disease becomes incurable. Not anymore. This is our worthy Chief Minister Kumar. This is what our Aam Aadmi Party government has done it. Health and education. These are our our priorities, and they are the most important, I would say, indicators of human development. So that's how the government should work. So we are focusing on health, we are focusing on education, and also on employment. When you have the universal health care, so there thousands and thousands of jobs will be created. If you invest same amount in defense and the same amount of education, you will get 10 times job in education or health. You will get maybe 20 times job in agriculture. But if you invest in defense if you make intercontinental ballistic missiles? Where does that money go ultimately? Those weapons become obsolete. Tanks have become obsolete. Mines have become obsolete. Armies have become nearly absolute. Now it used to be Air Force. Now even that has become, you see, useless. So now it's the missiles and the drones. So weapon systems become obsolete very fast. Food will never be obsolete. Medicine will never be obsolete. Education will never be obsolete. So this is where the governments need to focus. And you should all be aware. You are part of that process. Doctors ਮੋੜ ਪਾਣ ਨਹੀਂ ਜਾਂਦੇ ਡਾਕਟਰ ਨੇ ਤੁਹਾਡੇ ਵੀ ਸ਼ਾਇਦ ਉੱਥੇ ਪ੍ਰੋਬਲਮ ਹੋਏਗੀ ਸਾਡੇ ਤਾਂ ਬਹੁਤ ਪ੍ਰੋਬਲਮ ਹੈ ਉਹ ਤਾਂ ਆਉਂਦੇ ਨੇ ਇਹ ਛੁੱਟੀ ਕਰਾਉਣ ਚਲੇ ਜਾਂਦੇ ਨੇ ਚਲੋ ਮਨਾਲੀ ਚੱਲਦੇ ਆ ਬੱਚਿਆਂ ਨੂੰ ਲੈ ਕੇ ਜਾਂ ਘੁੰਮ ਫਿਰ ਆਉਂਦੇ ਸੋ ਇਟ ਇਜ਼ ਅ ਰਿਸਪੌਂਸਿਬਿਲਿਟੀ ਵਿਚ ਯੂ ਮਸਟ ਰਿਮੈਂਬਰ ਸੋ ਯੂ ਹੈਵ ਟੂ ਚੂਜ਼ ਪੀਪਲ ਹੂ ਪ੍ਰਮੋਟ ਐਜੂਕੇਸ਼ਨ ਐਂਡ ਹੈਲਥ ਸੋ ਵਿਦ ਥੀਸ ਵਰਡਸ I congratulate all of you and I hope this will be the beautiful because this is also a working holiday. Yes, and Dr. Vinay, we are very happy and pleased to say that the room you lived in at Pathology Lecture Theatre, this will be named in your name so that people remember it. We have the credentials. And your hostel room is already named. And this is my request to the faculty that people should know who is Dr. Vinay Kumar, what he has done is. There should be a complete description, a very brief description of that, and what he has achieved, and what you can, if you follow in his footsteps, what can you can do. So, sir, you are a guide, you are a mentor, you are the shining light for all of us. Thank you very much. I know you were the first one, when I came, you were sitting there. So, thank you very much.
So I call upon Dr. Karamjeet Singh Gill, Chief Advisor, to deliver a vote of thanks.
Good morning, everyone. It's my privilege and honor to propose the vote of thanks. First and foremost, I express my heartfelt gratitude to our esteemed Chief Guest, Dr. Balbir Singh, Honorable Minister for Health and Medical Education, Punjab, for consenting to be with us in this August gathering. Thank you, sir. And guest of honors includes Dr. Avinash Kumar, DRME, Dr. Pinder Kaur, Joint DRME, Dr. J.P. Atri, Vice Principal, Dr. Karamjeet Singh, Medical Student, Dr. Deepak Mishra, Dean ICP, Dr. Ritamra Nadda, ICP Secretary, Dr. Ranganathan, Coordinator APNA, Dr. B.S. Bajwa, PMC Member, Dr. S.P. Singh, Bajaj, Civil Surgeon, Dr. Vijay Bodal, Convener, Dr. K.D. Singh, Director TIMS, Dr. Parmeet Kaur Bagga, Organizing Chairperson and HOD, Dr. Jaspreet Singh, Organizing Secretary, and I see many faculty members and HOD of GMCs. So thank you very much everyone for joining us here. I would like to extend my sincere thanks to all distinguished speakers and panelists from APNA, ICP 2026 and others who contributed their knowledge, experience and time to make this conference meaningful and engaging. My appreciation goes to organizing team led by Dr. Parmeet Bagga, Dr. Vijay Bodal, education is the best investment. So thank you so much, Gian. Welcome. Thank you.
So this concludes the ceremony. So I request Dr. Kabir Singh, our working minister, to share a couple of questions. Thank you, sir.
Thank you so much everyone to be the part of this wonderful inauguration.
The breakfast has been served. Those who wish can proceed to the dining area. Due to paucity of time, we will begin with our academic session soon.
ਉਹਦਾ ਉਹਦਾ ਇਸ਼ੂ ਸੀਗਾ ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਸਰ ਕੀ ਹਾਲ ਹੈ ਸਰ ਠੀਕ ਹੋ ਗਿਆ ਮੈਮ ਹੋ ਗਈ ਹਾਂ ਕਰਦਾ ਮੰਡੇ ਕਰ ਅੱਜ ਮੈਂ ਡੇਰੀ ਦਾ ਆਹੋ ਸੋਮਵਾਰ ਸੁਬਾਹ ਅੱਛਾ ਕੀ ਹਾਲ ਹੈ ਸਰ
ਜਦੋਂ ਤੁਸੀਂ ਲਾਈਕ ਕੱਲ ਤੋਂ ਇੱਧਰ ਸੀਗੇ
ਮੈਂ ਨਹੀਂ ਬੋਲਿਆ
ਸਾਰੇ ਜਿਹਨੇ ਵੀ ਮਹੀਨਾ ਹੋ ਗਿਆ ਮੈਡਮ ਜੁਆਇਨ ਨਹੀਂ ਕਰ ਰਹੇ ਮੈਮ ਸਿੱਖੀ ਨਹੀਂ ਕਰ ਰਹੇ ਸਰ ਰਿਕਵੈਸਟ ਕਰਨਾ ਸਾਰੇ ਜ਼ਿਲ੍ਹੇ ਦਾ
ਕੱਲ ਦਿਖਾਣਾ ਹੁਣ ਐਵੇਂ ਬਸ ਵੰਸ ਨਾ ਬੋਲਣਾ ਮੈਂ ਜਵਾਨ
गिरा पड़ा। ये दिव्या वो लगाती है ऐसे नहीं
I will show it to her.
Yes, yes, please.
ਟੋਟਲ ਕਾਰਡ ਕਿੰਨੇ ਬਣੇ ਨੇ ਤੇ ਕਿੰਨੇ ਲੋਕ
ਬੇਨਤੀ ਹੈ ਜੀ ਮੇਰੀ 2:30 ਵਜੇ ਨਾ ਡੀਸੀ ਆਫਿਸ ਦਾ ਮੈਂ
2:30 ਵਜੇ ਡੀਸੀ ਕਰਾਂਗੇ ਆਪਾਂ ਦੁਬਾਰਾ
ਬਹੁਤ ਵੱਡੀ ਅਨਾਉਂਸਮੈਂਟ ਕਰਨੀ ਹੈ ਕਿ ਸਾਡੇ ਇੱਥੇ ਬੰਦਾ ਸੀਗਾ ਉਹ ਨਕਲੀ ਹੈਲਥ ਮਿਨਿਸਟਰ ਬਣਿਆ ਹੋਇਆ ਸੀ ਤੇ ਉਹਦੇ ਬਾਰੇ ਵੀ ਮੈਂ ਗੱਲ ਕਰਨੀ ਹੈ ਕਿ ਜਿਹੜੀ ਇੰਸ਼ੋਰੈਂਸ ਸਕੀਮ ਹੈ ਉਹਦੇ ਵਾਸਤੇ ਸਾਰੇ ਮੇਰੀ ਵਿਜ਼ਿਟ ਉਹਦੇ ਵਾਸਤੇ ਉਹ 2:30 ਵਜੇ ਆਪਾਂ ਡੀਸੀ ਆਫਿਸ ਮਿਲਣੀ ਹੋਈ।
ਹਾਂਜੀ ਹਾਂਜੀ
AI ਜਿਹੜੀ ਹੈ ਤੁਸੀਂ ਅੰਦਰ ਗੱਲ ਨਹੀਂ ਕੀਤੀ ਬਟ AI ਜਿਹੜੀ ਹੈ ਆਉਣ ਵਾਲੇ 2-3 ਸਾਲਾਂ ਫਿਜ਼ੀਸ਼ੀਅਨ ਦੀ ਜੌਬ ਜਿਹੜੀ ਉਹ ਖਤਰੇ ਹੈ।
ਦੇਖੋ ਇਹਦੇ 'ਚ ਨਾ ਜਦੋਂ ਪਹਿਲਾਂ ਇੰਡਸਟਰੀ ਆਈ ਜਿਵੇਂ ਟਰੈਕਟਰ ਆ ਗਿਆ ਉਹਨੇ ਬੈਲ ਨੂੰ ਰਿਪਲੇਸ ਕਰ ਫਿਰ ਮਸ਼ੀਨ ਆਪਣੇ ਹੋਰ ਦੂਜੀਆਂ ਚੀਜ਼ਾਂ ਆਈਆਂ ਉਹਨੇ ਫਿਜ਼ੀਕਲ ਲੇਬਰ ਨੂੰ ਜਿਵੇਂ ਹੁਣ ਤੁਹਾਡੇ ਹਾਈਵੇ ਬਣਦਾ ਹੈ ਸੜਕ ਬਣਦੀ ਹੈ ਜਾਂ ਤੁਹਾਡੇ ਗ੍ਰਿਡ ਬਣਦਾ ਪਹਿਲਾਂ ਉਹਦੇ ਸੈਂਕੜੇ ਬੰਦੇ 11 ਬੰਦੇ ਕੰਮ ਕਰਦੇ ਹੁਣ ਇੱਕ ਜੇਸੀਬੀ ਮਸ਼ੀਨ ਕਰਦੀ ਉਹਨੇ ਫਿਜ਼ੀਕਲ ਲੇਬਰ ਨੂੰ ਰਿਪਲੇਸ ਕਰ ਜਿਹੜੀ AI ਹੈ ਉਹਦੇ ਵਿੱਚ ਤੁਹਾਡੇ ਕੋਲ ਜਿਵੇਂ ਇੱਕ ਵਕੀਲ ਹੈ ਤੁਹਾਡੇ ਵਾਸਤੇ ਸਮਝਣਾ ਸੌਖਾ ਹੋ ਗਿਆ ਇੱਕ ਵਕੀਲ ਹੈ ਉਹਨੇ ਆਰਗੂਮੈਂਟ ਉਹਨੇ ਕਿੰਨੇ ਕੇਸ ਹੈ ਜਿਹੜਾ ਇੱਕ ਵਕੀਲ ਨੇ 3 ਦਿਨ 'ਚ ਕੰਮ ਕਰਨਾ ਉਹ 3 ਮਿੰਟ 'ਚ ਕਰਦਾ ਕਿਉਂਕਿ ਉਹਦੇ ਕੋਲ ਸਾਰਾ ਦੇਖਣਾ ਉਹਨੇ ਦੇਖ ਲੈਣਾ ਕਿ ਸਿਮਿਲਰ ਕੇਸਿਸ ਕਿਹੜੇ ਆ ਕੀ ਆਰਗੂਮੈਂਟ ਬਣਦੀ ਹੈ ਸੋ ਜਿਹੜੀ ਇੰਟੈਲੈਕਚੁਅਲ ਲੇਬਰ ਹੈ ਜਿਹੜੀ ਚਾਹੇ ਉਹ ਵਕੀਲ ਹੈ ਚਾਹੇ ਉਹ ਡਾਕਟਰ ਹੈ ਚਾਹੇ ਉਹ ਟੀਚਰ ਹੈ ਜਿਵੇਂ ਟੀਚਰ ਜਿਹੜਾ ਬੱਚਾ ਹੈਗਾ ਉਹ ਰਿਲੈਕਟਡ ਹੈ ਆਪਣੇ ਟੀਚਰ ਨੂੰ ਜਾ ਕੇ ਸਵਾਲ ਪੁੱਛਣ ਦਾ AI ਨਾਲ ਨੂੰ ਹੈਜ਼ੀਟੇਸ਼ਨ ਇਸੇ ਤਰ੍ਹਾਂ ਡਾਕਟਰ ਐਕਡਮਿਕ ਸਪੋਜ਼ ਤੋਂ ਐਪਲਿਕਟ ਹੈ ਉਹ ਸ਼ਰਮਾਂਦਾ ਹੈ ਮਾਂ ਪਿਓ ਨੂੰ ਨਹੀਂ ਦੱਸਦਾ ਮਾਂ ਪਿਓ ਲੋਕਾਂ ਨੂੰ ਨਹੀਂ ਦੱਸਦੇ ਬਟ ਕਿਉਂਕਿ ਇਹ ਫੇਸਲੈਸ ਹੈ ਜੇ AI ਹੋਏਗੀ ਤਾਂ ਸ਼ਾਇਦ ਆਪਣੀ ਸਾਰੀ ਬਿਮਾਰੀਆਂ ਨੂੰ ਦੱਸ ਸੋ ਇਸ ਕਰਕੇ ਇਹ ਆਉਣ ਵਾਲੇ ਦਿਨਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜੀ ਹੈਗੀ ਹੈ ਨਾ ਉਹ ਪਹਿਲਾਂ ਜਿਹੜੀ ਸੀ ਜਿਹੜੀ ਮਸ਼ੀਨ ਉਹਨੇ ਫਿਜ਼ੀਕਲ ਲੇਬਰ ਨੂੰ ਰਿਪਲੇਸ ਕੀਤਾ ਤੇ ਜਿਹੜੀ AI ਹੈ ਇਹ ਇੰਟੈਲੈਕਚੁਅਲ ਲੇਬਰ ਨੂੰ ਰਿਪਲੇਸ ਕਰੇਗੀ ਨਾਲ
ਕਿੰਨਾ ਕੁ ਖਤਰਾ ਹੈ?
ਮੈਂ ਇਹਨੂੰ ਖਤਰਾ ਨਹੀਂ ਸਮਝਦਾ ਦੇਖੋ ਜੀ ਟੈਕਨੋਲੋਜੀ ਦਾ ਉਹਦੇ ਵਿੱਚ ਮੈਨ it's a positive kind of a competition. We have to stay ahead of it. We have to learn how to use AI and not let the AI use it.
ਦੋਸਤੋ ਜੀ ਗੱਲ ਕਾਫੀ ਚਲੋ ਪ੍ਰੈਸ ਕਾਨਫਰੰਸ ਇਸ ਤੋਂ ਇਲਾਵਾ ਜੇ ਗੱਲ ਕੀਤੀ ਜਾਵੇ ਸਿਵਲ ਹਸਪੀਟਲ ਰੈਂਕਿੰਗ ਦੇ ਵਿੱਚ ਬਠਿੰਡਾ ਨੰਬਰ 1 ਤੇ ਹੈ ਅੰਮ੍ਰਿਤਸਰ ਕਦੀ ਨੰਬਰ 1 ਹੈ ਕੀ ਕਾਰਨ ਸਮਝਦੇ ਹੋ ਅੰਮ੍ਰਿਤਸਰ ਦਾ ਸਿਵਲ ਹਸਪੀਟਲ ਜਿਹੜਾ ਉਹ ਰੈਂਕਿੰਗ ਪਿੱਛੇ
ਦੇਖੋ ਮੈਂ ਬੇਸਿਕਲੀ ਇਹ ਸਮਝਦਾ ਕਿ ਇਹਦੇ ਵਿੱਚ ਕਿਤੇ ਨਾ ਕਿਤੇ ਜਿਹੜਾ ਆਪਣੇ ਮੌਕੇ ਤੇ ਐਡਮਿਨਿਸਟ੍ਰੇਟਰ ਜਿਹੜਾ ਸਭ ਆਪਣੇ ਨਾਲ ਕੱਲ੍ਹ ਮੈਂ ਲੁਧਿਆਣੇ ਗਿਆ ਲੁਧਿਆਣੇ ਦੇ ਵਿੱਚ ਮੈਂ ਜਾਂਦਾ ਸੀ ਮੇਰਾ ਬੜਾ ਮਨ ਖਰਾਬ ਹੁੰਦਾ ਸੀ ਪੂਰੇ ਹਾਊਸ ਬਹੁਤ ਵਧੀਆ ਸੀ ਸਾਰੇ ਹਸਪਤਾਲ ਦੀ ਸਾਰੀ ਸੁਵਿਧਾ ਔਰ ਪਹਿਲਾਂ ਇਹਨਾਂ ਕੋਲ ਰਿਸੋਰਸਿਸ ਨਹੀਂ ਹੁੰਦੇ ਸੀ ਜਿਵੇਂ ਇਹਨਾਂ ਨੇ ਸਟਾਫ ਰੱਖਿਆ ਹੁਣ ਇਹਨਾਂ ਕੋਲ ਰਿਸੋਰਸਿਸ ਦੀ ਕਮੀ ਹੈ ਸਾਡੀ ਆਲਰੇਡੀ ਜਿਹੜੀ
आप बना रहे हो हमारा कुछ वीडियो ले ले मैं नहीं गलत फाइल में ये बोल रही हूं मतलब आप लंच के लिए नहीं ऑडियो का नहीं होना वीडियो बना लो
ਉਹਨਾਂ ਦੀ ਯਾਰ ਇੱਧਰ ਥੋੜਾ ਵਾ ਉਹਨਾਂ ਦੀ ਹੈਗੀ ਮੈਂ ਕੀ ਕਹੂੰਗੀ ਇਹਨਾਂ ਦਾ ये मशीन की है, इसमें भी हमने अपना AI की बात करें तो इसके अंदर भी हमने AI हमने निकाला है। हर पेशेंट के उसमें रिपोर्ट में कुछ एनालिसिस करता है। रेस्ट जो पार्ट है पैथोलॉजी, पैथोलॉजिस्ट का जो काम है अदर इक्विपमेंट्स ऑल्सो। ये हमारा सर नया लॉन्च है HbA1c एनालाइजर बेस्ड ऑन द जी सर काम कर ऑटो एनालाइजर सर AI में आ गया है, मेरे पास आया था जी, उसने सारे टेस्ट की रिपोर्ट दी और मेरे पास दे दिया।
ये सर AI फीचर है सर, ये हमारे पास स्लाइड डिजाइनर के बाद स्लाइड को रिव्यू करता है तो उसकी मेमोरी में करना और AI से मैच करता है। टेक्नोलॉजी हम यूज़ कर रहे हैं सर,
बहुत बढ़िया अच्छी टेक्नोलॉजी है सर, लेकिन चैलेंज ड्रॉप मत सर वो भी सर पीछे स्टेजिंग करेक्ट
But I will text. Yeah.
ये वो कर देगा सारा ये सारा प्रोसेसिंग करेगा।
सर वो सर एक गोल्डन टेम्पल गोल्डन
आएगा कुछ सर एक सेल्फी बूथ पे आपके साथ फोटो
चंगा मैं अज मैं आप आ गया कल मुंडा भी जाए कल लोग फंक्शन नहीं थी कल भी गल हुई इन्होंने कहा भी की बात अंगा भी पार्टी कन्वर्ट उनके पार्टी नहीं गाई नहीं बस थोड़ा ब्रेकफास्ट से करता ना करो आज आयो मैं ना आयो आयो चले आयो क्या
ਜਿਵੇਂ ਮੈਡਮ ਕਹਿੰਦੇ ਸੀ ਕਿ ਮੈਂ ਤੇ ਕਿਸੇ ਹੈਲਥ ਮਿਨਿਸਟਰ ਜਾਂ ਐਮਐਲ ਤੋਂ ਵੀ ਨਹੀਂ ਡਰਦੀ ਹੈ ਨਾ ਮੈਡਮ ਮੀਟਿੰਗ ਦੇ ਵਿੱਚ ਸਾਨੂੰ ਸ਼ਰਮ ਚੀਜ਼ ਬੋਲ ਦਿੰਦੇ ਸੀ ਕਿ ਮੈਨੂੰ ਇਹਨੂੰ ਕੋਈ ਨਹੀਂ ਹਿਲਾ ਸਕਦਾ ਮੈਨੂੰ 15-16 ਸਾਲ ਹੋ ਗਏ ਆ ਤੁਸੀਂ ਤੇ ਮਤਲਬ ਕੱਲ ਦੇ ਆਏ ਬੱਚੇ ਹੋ ਤੇ ਤੁਸੀਂ ਕੀ ਕਰ ਸਕਦੇ ਹੋ ਪਰ ਚਲੋ ਜੇ ਸਾਡੀ ਜੌਬ ਜਿਹੜੀ ਹੈਗੀ ਆ 5-6 ਸਾਲ ਤੋਂ ਹੀ ਆ
आयो चलता बिल्कुल 28 मिनट तक
in 1990s when liquid-based pathology was also introduced. Along with that, in 1990s, there was FDA approval for DNA testing as a primary screening method. Now in 2020s, we have moved on. Now we have AI-powered screening of pap smears. As per WHO in 2024, cervical cancer is the 4th most common cancer in women globally, with around 660,000 new cases and around 350,000 deaths in 2022. The highest rates of cervical cancer incidence and mortality is in low and middle income countries, and we all know the reason. There is lack of access to national HPV vaccination programs and to the cervical screening programs and to the treatment services. Prophylactic vaccination against HPV and routine screening and treatment of pre-cancer lesions are effective strategies to prevent cervical cancer and are very cost effective. If diagnosed early and treated promptly, cervical cancer can be cured. This is the global landscape of cervical cancer incidence and mortality. The top map shows the incidence rate and the bottom one shows the mortality. The yellow star areas show the highest rates of highest incidence and highest mortality rates, and the red star regions are the regions which show the lowest incidence and lowest mortality rates. Since the adoption of conventional PAP in 1950s, there have been several technological advances to improve and automate PAP tests. The conventional PAP screening was always existing. It's a mundane task. It is prone to error and causes ergonomic injuries. When I was in the Indian Army, we used to conduct a whole lot of cervical screening camps. And by the end of the day, we would get a lot of conventional smears to review. And by the end of the day, my back used to be like this. I'm so thankful that now we have computer-assisted liquid-based cytology available for screening of PAPs. This has really improved the sample quality, the cells are better preserved, and they are highly sensitive with lower false negatives. And there has been reduction in the unsatisfactory results as well. cytology. With the modern digital cytology systems, we have better image focus, and with the artificial intelligence, we can pick up multiple cellular findings, and that is a boon to us. In March 2024, WHO agreed on 3 targets to be met by 2030 to help eliminate cervical cancer. First of that is that 70% of the women should be screened with a high-quality test by ages 35 and 45. Second, 90% of the women with cervical disease should be receiving treatment. Third, 90% of the girls should be vaccinated for HPV by the age of 15 years. The AI tools for screening PAPs are based on the Bethesda system of reporting cervical cytology. And in the Bethesda system, adequacy is one of the important features, and it is defined as the number of well-visualized and well-preserved squamous or squamous metaplastic cells. For a conventional smear, the number is about 8,000 to 12,000 such cells. In a liquid-based preparation, the number is about 5,000 cells. In patients who have received chemotherapy, radiotherapy, or postmenopausal women, this number can be reduced to less than 5,000 and is still considered adequate. The exception to the rule is that if there is any abnormal cells present, the count doesn't matter. According to the Bethesda system, the pap smears are categorized into 3 categories. We have the negative for intraepithelial lesion or malignancy, in which the variants are also included, like you have the squamous metaplasia, tubal metaplasia, and atrophy. Even the organisms are included in this category. In the other category, the presence of endometrial cells in women ages above 45 is being reported. And then we have the epithelial cell abnormalities, which can be squamous as well as glandular. In 2024, the Digital Cytology Task Force conducted a survey to compare the scanning of digital slides in surgical pathology versus those in cytology. And here in the top graphs, you can see the comparison is based on the practice region. In North America, 69% of surgical pathology is being scanned, but cytology is only 42%. In the bottom 2 graphs, you have a comparison between the practice setting. So for surgical pathology in academic center, there is 73% slides being scanned, while in cytology, there is only 46%. There is a vast difference in scanning. This is because of the challenges that we have in cytology. In histology, you have a thin section, you have a uniform section. So imaging is possible. But in a cytology smear, it's a smear which is larger in size. It has got 3D clusters present in it. The focal planes are different. As a result, the traditional imagers are not able to produce a good enough image for evaluation for a cytology specimen. Now we have the modern digital cytology systems, and these systems are based on digital whole slide imaging combined with artificial intelligence technology. One such system is the FDA-cleared Genius Digital Diagnostic System. And this combines deep learning-based AI algorithm analysis with advanced volumetric on the right top corner, which you can access anytime if you want to. This is the gallery that is shown here, and here,
and most importantly, do not mistake this for a carcinosarcoma. The next case is a 74-year-old woman presented with postmenopausal bleeding. Imaging showed thickened endometrium, and in addition, the tumor involved cervix and vagina, and so they did biopsies of the cervix and vaginal wall. So we got big chunks of biopsies, and even here at this part, you can see there's a lot of necrosis and some showing proliferation of cells which look squamous. You can see quite a bit of keratinization happening here. There was a lot of tumor necrosis, and what we also see are these ghost cells, or what we call shadow cells, where you see the contours and the ghosts of the nuclei adjacent to this geographic necrosis, and the cells look very high-grade and basaloid. So the stains that were done, keratin was diffusely positive, EMA was patchy, and PAX8 was negative in this tumor. P16 was pretty positive, but not as strong as what you would expect in HPV-related squamous cell carcinoma. P53 was wild type. So the initial diagnosis that was given was a poorly differentiated squamous cell carcinoma. And then the patient was referred, and I had to review the biopsy. So I sent it for high-risk HPV staining, which came back negative, and meanwhile the patient got an MRI. So the MRI showed that the mass was in the endometrium as well as the cervix. The pelvic lymph nodes were positive. There was also lung nodules as well as hilar lymph nodes, so there was extensive disease. And then finally, beta-catenin showed nuclear localization in these cells. So this is a pilomatrix-like high-grade endometrioid carcinoma, or endometrial carcinoma as it is now recommended to call this. This was actually initially described in 1996 as a pilomatricoma-like endometrioid adenosquamous carcinoma of the ovary with neuroendocrine differentiation, because at that time they found synaptopachysin was positive in these tumors. And more recently, there have been multiple case reports and smaller series coming out talking about this entity, because usually it gets mistaken either as a squamous cell carcinoma or on hysterectomies as a grade 3 endometrioid carcinoma because of the extensive squamous differentiation that is thought to be metaplasia. Now this is a newly described tumor. It is not there yet in the WHO edition, the 5th edition, nor is it there in the FIGO 2023 staging. But this is a this tumor has the same pattern. I showed you multiple pictures. It has this nested pattern with high-grade basaloid tumor cells, geographic necrosis. There's prominent squamous differentiation and shadow cells which look like the cutaneous pilomatrix carcinoma. And they classically stain for neuroendocrine markers and CDX2. They do not show PAX8 and ERPR, which helps to differentiate from a grade 3 endometrioid carcinoma. And they show nuclear beta-catenin staining, and they show, again, the exon 3 CTNNB1 mutation, very similar to the check and spindle endometrioid tumors. So they again fall in the no specific molecular profile category, but in contrast to the previous tumor, these are very aggressive and have a very poor outcome. So again, just showing the morphology of this tumor. The differentials, of course, because it frequently involves the cervix because it's high stage and you get a small biopsy with squamous cells, it's you would think it's a squamous cell carcinoma. And but whenever you get that and you do P16 and high-risk HPV, if it's negative, this is something to think about, because of course you can get HPV-independent squamous cell carcinomas of the cervix, but they're very, very rare. So you want to think of an alternate diagnosis before calling it that. Again, the high-grade endometrioid grade 3, I talked about that, and you can use ER, PR, PAX8 to differentiate.
necessary will not help differentiate. And these could also be mistaken for high-grade neuroendocrine carcinomas because of the neuroendocrine staining, and therefore the morphology along with beta-catenin nuclear staining is important to clinch the diagnosis in this case. So again, think about this entity when there are basaloid cells, extensive abrupt keratinization shadow cells. This is the immunoprofile, and again do a high-risk HPV to help differentiate from cervical square. Moving on to the next case. This is a young woman, 24, nulliparous, a little overweight, BMI 40, presented with irregular vaginal bleeding. And on colposcopic exam had polypoid masses protruding into the cervix from the endometrium, and biopsies were taken. So we got a very generous sample, and you can see at this power that it has a few patterns here. You have some elongated papillae, and there is some other more solid-looking areas here. So I'm going to first focus on this area, and then I'll come back to this larger area. So this was the top right area, and at this power itself, you can see there are some glands and what looks like some squamous differentiation. We'll look at high power. And this looks like a low-grade endometrioid carcinoma. You have glands that are back-to-back with that look like proliferative endometrium, and you have squamous differentiation. I think most people would agree that this would be like a 501 endometrioid carcinoma. Higher power looking at the nuclei, there's some cribriforming that you can see, but the nuclei show mild to moderate atypia. There's no pleomorphism. There's pseudostratification, but overall the polarity seems okay, pretty well maintained. No marked atypia seen, not much of appreciable mitosis. Of course, there is always some. And then going to the other area that we saw that looked a little different. These are the elongated papillary structures that you can see. Again, high power, just to show these papillary structures. And you can see some glands on either side here. The nuclei here definitely look different from the first area that I showed. Here they have, they look larger. They're more vesicular with some prominent nucleoli, and there is quite a bit of loss of polarity in some areas. But overall, it's like moderate atypia, not severe, not much pleomorphism. And then there was one area that was marked by the green, which looked like this. It was a little distinct. And here you have more solid, a little bit of papillae on the surface. You can see some hobnailing of the cells, cuboidal cells with the nuclei kind of falling off the top, and some clearing of the cytoplasm, reminiscent of a clear cell carcinoma pattern, right? So immunostains were done. This was again done on the outside. So P16 showed patchy staining. ER was positive. This is the component which looked like grade 1 endometrioid, the more papillary component. The ER and PR were stronger in the low-grade endometrioid. This area also had ER and PR though, but not as strong. So the outside diagnosis was endometrioid carcinoma 501, but total clear cell carcinoma cannot be ruled out. And ER and PR were patchy positive, and so they sent it for a consultation. So again, this is the endometrioid component, which I agreed with. I thought it was low-grade endometrioid carcinoma. But this component looks a little different. Again, we talked about the patterns. And this is the nuclear features that you can see. Here you have some scalloping of the borders inside, and here you have again the hobnailing and the clear cell-like features. Here you have some eosinophilic material within the glands, and again here you have the higher grade nuclear features. So I added some stains. So this is TTF1, and you can see that the papillary area is diffuse and strong, and the endometrioid component is negative. GATA3 was not as dramatic, but still you can see some patchy staining, and again negative in the endometrioid component. This is again the same stains, but showing the dramatic difference. So you can see the areas that were all endometrioid were negative for TTF1 as well as GATA3. and the other areas were diffusely positive. So this is a mixed endometrioid and mesoelectric-like adenocarcinoma of the endometrium. ER and PR, interestingly, were positive in both components, and TTF1 and GATA3 were positive only in the mesonephric-like component. MMR was proficient, and P53 was wild type. So a little bit about mesonephric carcinomas. So the mesonephric adenocarcinoma of the cervix tends to be associated with the mesonephric hyperplasia and remnants, and is usually in the lateral wall of the cervix. The mesonephric-like adenocarcinoma of the endometrium does not have association with the remnants and does not show hyperplasia, and is thought to be a Müllerian carcinoma with mesonephric differentiation. Again, it was originally reported in 2016 by Professor McLuggage, and then subsequently there was a large series from MD Anderson, and then a multi-institutional series in 2021, and then more recently we had this the mesonephric-like adenocarcinoma consortium that came up with diagnostic criteria and guidelines just published last month in the International Journal of Gynecologic Pathology. So these tumors are seen in a wide age range group, but usually in postmenopausal women. The youngest was in the MD Anderson series I found, that was 30 years. Our patient was 24. They show a wide variety of architectures. You have tubular, papillary, the pseudoendometrioid, glomeruloid. All of these can be seen in other Müllerian carcinomas, and therefore these can be frequently mistaken for them. The cytology shows moderate atypia, so slightly more atypical than the typical endometrioid carcinomas, but not as bad as serous. And the nuclei resemble that of papillary thyroid carcinoma with the open chromatin orphan like nuclei overlapping powdery chromatin. And frequently you could see the clear cell-like picture with the hobnail. So the recommendation from this group and then this paper is that you do a frontline panel of TTF1 GATA3. It should be positive. One of them can be positive. It doesn't have to be both. Usually one is positive. ER and PR should be negative. Secondary panel recommended is CD10 and PAX2. Both of these would be positive. SOX10 is another secondary marker they recommend, and it's unique that it is only negative in mesonephric-like adenocarcinoma or mesonephric carcinomas of the cervix, but it's positive in all other Müllerian carcinomas. PAX8, of course, would be positive, so it won't help differentiate from other Müllerian carcinomas, and usually MMR is intact and P53 is wild type. Similar to the mesonephric carcinomas of the cervix, these show KRAS mutations and 1q gains. But in contrast to the cervical tumors, these also show abnormalities in Müllerian genes, PIK3CA, PTEN, and beta-catenin, and no P53 poly or MMR gene mutations have been identified in these tumors. So again, it's a rare tumor, but more than 50% of the patients present with advanced stage disease. They show increased lymphovascular invasion, high frequency of pulmonary metastases, very high recurrence rate, and approximately 80% of these tumors are diagnosed as something else. So these definitely are under-recognized. So again, take-home message is these are rare, under-recognized, but now what's happening is everyone's doing TTF1 GATA3 even when there's not the correct morphology, and so they tend to get over-diagnosed. So again, the paper that I just mentioned emphasizes that correct morphology is essential for diagnosis. Immunohistochemistry and molecular studies should only be used as confirmatory tools and not substitutes for morphologic assessment. And accurate diagnosis, of course, is essential because this is an aggressive subtype of endometrial carcinomas and could have distinct therapeutic implications. I'll move on to my next case. 75-year-old woman, postmenopausal bleeding, endometrial biopsy is performed. So here we have a tumor which has solid areas, but some areas maybe you can see some glands or some papillae. Most Müllerian tumors have this kind of pattern, some glands, some papillae, some solid areas. But at this tower itself, you can see that it is has pretty pleomorphic nuclei, little high grade, clearing of the cytoplasm or vacuolation of the cytoplasm. Again, single cells, cuboidal to columnar to flattened, lining these glands or the papillary structures. Again, nuclear pleomorphism is apparent, and there's not much by a way of mitosis. You do see some apoptotic bodies. There was some areas showed a lot of geographic necrosis. Again, so this was signed out again on the outside without any immunostains, and usually that's rare. I always see more and more immunostains performed, but this was signed out without immunostains as clear cell carcinoma. And on first look, I agreed with it. But then I was uncomfortable because, again, we are so used to doing immunostains. I said, okay, let me do a couple of immunostains and see if they stain. And usually, clear cell carcinoma, it is pretty, it stains many things, or it doesn't really stain for a lot of things, like ER and PR can be diffusely positive or negative or patchy, so that's not a good stain to do. Napsin and Amicar are, if they're positive, they're good, but if they're negative, it doesn't rule out a clear cell. So the only consistent stains that usually are positive are Paxi and CK7. So I did the two stains. Both of them were dead negative in this tumor. So then I was initially shocked, and I said, okay, what are the mimics of clear cell? What else could it be? First, we need to make sure whether, the stain's actually working, but it did. So went ahead and did some more stains. Any clues? Does anybody have an idea? Any PGs? What do you all think this could be? No idea? No guesses? Yeah. So this is SAL4 and CDX2, diffusely positive in this tumor. And this tumor is known to be a great mimic of clear cell carcinoma. It's just that it is very rare in the endometrium. So this is the yolk sac tumor of the endometrium. So extragonadal germ cell tumors are very rare. You can see them in the vagina, vulva, cervix, or the endometrium. And there are several histogenetic mechanisms, but in the endometrium, we think it's because of, again, transdifferentiation or specialized differentiation from a somatic carcinoma. The paper from MD Anderson talks about how this is still a diagnostic challenge in this paper. Almost all the cases that they received as consult were called something else. And again, this paper came out just now in Modern Pathology this month, and they did the molecular testing in a bunch of these somatically derived endometrial yolk sac tumors. So again, it's the most common extragonadal germ cell tumor seen in postmenopausal women, and you can see all the histologic patterns of yolk sac tumors that you see in the ovary, and they do mimic somatic neoplasms, and because it's, again, thought to be transdifferentiation, it's associated with other miliary neoplasms, endometrioid, serous, clear cell, carcinoma, triple NT. Here we have the reticular pattern, the pseudo-endometrioid, papillary, solid. It's the more mucinous pattern, and here we have the classic Schiller-Duval bodies that are marketed very well in these tumors, but very rare to find. So this is a table from the MD Anderson paper where they talk about the stains that are used to differentiate, but I think when you think about it or when you want to rule it out, the SAL4, Glypican-3, CDX2 are very good stains. AFP, at least in my lab, it's not a good stain to interpret, so I don't do that. And these tend to be Pax8, ER, PR negative. Keratins can be variable, so yolk sac can sometimes stain for keratins, but EMA tends to be negative. And again, this paper shows that based on the TCGA classifications, 73% of these tumors have TP53 mutations. There was 17% of no non-specific molecular profile, and 9% were MMR deficient, and there were no poly mutations. So this is a rare tumor in the postmenopausal age group. Again, greater than 50% present with low-stage disease. However, 75% of these patients died of disease or are alive with disease. So therefore, this should be considered high grade, and currently there are no specific guidelines for adjuvant therapy for these So again, these tumors are rare and therefore under-recognized. Although histologic features are identical to the gonadal counterparts, because of the unexpected location and because they look like other malarial tumors, they can be misdiagnosed. And in view of the poor prognosis, it is crucial for pathologists to recognize this component of a somatically derived youth sac tumor. I have one more case, but I'm going to skip it and I'll take questions in the interest of time.
Any questions?
Thanks, Devon.
Low-grade endometrioid component. And it was, I think, a year ago, and I put in a CDX2, which was strong. Thankfully, it was a minor component, and I put in a SAT-B2, which was strong, put in a beta-catenin, which was strong, and I thought they were immature squamous modules. There was focal necrosis, which initially I did not pay attention to, because it wasn't the typical tumor necrosis, and the remaining tumor, the endometrioid, was, I think, a FIGO2. And I said there's immature squamous metaplasia, squamous modules. Within 4 months, there were pulmonary mets, which showed the typical necrosis. And it was, I'm so proud to say, my junior colleague who brought it up, and this was just coming up at that time, this pyelomatricoma-like. And then she's had another case, and I think she's writing up both of them. And so we learn every day, and we recently saw both the cases together, and I think she will write it up. So brilliant. The first time I did really think it was low grade with immature squamous modules, but on hindsight it did have some, not as many host cells shown, but yes. So we have to keep a lookout for that. Morphologically, how would you distinguish squamous modules from these
I think what is recommended is that you have a low threshold once you see a lot of tumor necrosis and you see the ghost cells, because then you just do your immunostains. You do the synaptophysin, the CDX2, and the beta-catenin. Again, ERPR and Paxate is something we do routinely, so those are negative. So
both, they'll be negative in both squamous modules as well as in, you won't get them very strong in the squamous modules.
True, but in the whole tumor it's negative. So it kind of helps, but again, you have to have that index of suspicion, because otherwise, yes, I think in fact all the studies that have been shown, when they went back, they retrospectively looked at their grade 3 endometrioid and then went back and did the staining, and that's how they found these cases, right? Because they came back with lung mets.
Lung mets have only the basaloid cells. It didn't even have the glandular component.
Absolutely. So I think just a high index of suspicion and knowing that these exist is important to work it out.
And regarding the caudal hyalinized pattern, what if you showed again a low-grade component with it? What if we have a higher-grade tumor and with some small foci which are mimicking an undiff, a D-diff component? How would you address
So you
that?
have to go with the grading of that. Those tumors are done based on the endometrioid component. So if you have a D-diff, that's going to trump the other morphologies. But these are just for recognizing and not calling it a carcinosarcoma. But you're right, I've seen undiff along with the check pattern. And usually the check is like a minor pattern you recognize and you go. It's not the major pattern of the tumor many of the times. I've seen grade 3s with the check. But when the check is predominant, if you look at the studies, most of them tend to have the low-grade endometrioid. Which is why I said, though they say overall it has a favorable prognosis, there are those cases where there are undiff and other things associated, where the undiff is obviously going to dictate the prognosis of the tumor.
Thank you.
Just wanted to say excellent cases and beautiful presentation. It makes me look at a closer look at all the endometrial lesions that we see.
Singh and Dr. Vinay Sharma to come on stage and felicitate our speaker and chairpersons. A huge round of applause for them, please. Dr. Poonam, can you please come on stage and felicitate our speaker and chairpersons? Thank you so much, ma'am. A round of applause for them, please. Thank you, ma'am. Thank you, sir. For our next session, I invite our Honorable Chairpersons, Dr. Swaran Kaur, Professor and Head, Bhagat Pur Singh, Government Medical College, Sonipat, Dr. Monica Garg, Professor, Government Medical College, Government Medical College, Patiala, and Dr. S.P., former Professor and Head, Government Medical College, Amritsar, and currently working as Professor and Head in Medical College, Jammu. Please welcome them with a huge round of applause. The topic for this session is triple negative breast cancer, molecular profile. Orientation, margin assessment, and representative sampling directly determines diagnostic accurate, staging, and obviously patient management. So, to throw light on this topic, crossing of breast lesion, I invite Dr. Kamalji to share their insight on this topic. Dr. Tom Casey, Associate Professor of Pathology and Laboratory Medicine, Baron Albert Medical School of Brown University. He is Director of Breast Pathology, Director of Women's Health Fellowship, expertise interest, breast and the gynecology pathology. Welcome, Dr. Kamalji.
Thank you, ma'am. So I will start with a few words from fifth group. I think it's appropriate in the setting and the location. Uto anda paranka, maram payo pragas, kati vedi pagete, gurkini band class. The verse syncs very well with what we're doing here. The fifth guru says, knowledge is guru, and guru helps to break the shackles of ignorance. So, in the next 30 minutes, I'll talk about the grossing of breast specimens. And I was thinking about it, it's important. And why is it important is it sits at this crucial stage where you have the clinical presentation and you're about to examine the slides. And in breast, when you are making a report, my setting, we do a lot of work to find out the extent of the disease. So sometimes there are calcifications, sometimes there are mass, and when we are doing the gross examination, we really have to explain everything that has led to that excision. And every excision, at least in my setting, is very measured. And we will talk about that. Other important critical thing, if there are residents and fellows in the hall, once you have grossed it, especially when you have grossed it, you cannot really go back and put it together. It's really hard. So I will ask, anytime you have a breast specimen in front of you, maybe take a pause, 5 seconds, and think about it. Why is it taken out? And what are you expecting to find in it? That will help. Basically knowing the clinical and the radiological findings. So we will talk about the different types of breast specimens that you can get, how to orient them, ink them, fix them, how do you serially slice them, how do you note down the gross findings? Because a good gross description is really what your attendings need when they're looking at the slides, and it really helps. And how do you submit the sections? I bike, but 5 years ago I thought all kind of bikes are same, but this is a mountain bike, you can't take it on the road. This is a road bike, and this is a commuter bike. So breast specimens are kind of similar. They all look yellow, fatty, but they're not the same. So what are the types of breast specimens? So you can divide them broadly into 2 types, and that's what CAP, College of American Pathologists, do. They will say mastectomy, and then anything less than mastectomy. And further, these 2 types can be of more types. Like mastectomy can be simple, can be modified radical, and radical mastectomy. And then if you don't have a mastectomy, you can have a small biopsy, excision biopsy, wide local excision, and partial mastectomy. And each of but just by looking at the number of specimens, you can tell that each of them are done in a very particular scenario. So what is mastectomy? Everybody knows about radical mastectomy, I hope, in this room, and at least in my setting, I don't see radical mastectomy, and I rarely see modified radical mastectomy. It's just the practice and the epidemiology of the disease that we have in, at least in the United States. So I will see maybe 1 or 2 modified radical mastectomy in a year or 6 months. And the goal of a mastectomy is to remove the entire breast tissue. So basically the surgeon goes below the skin, goes all the way to the pectoralis fascia, and they go around the fibroglandular boundary of the breast. Although they try it, but they know that they're not going to remove the whole thing. There's still some breast tissue left. Whenever I see a mastectomy specimen, I immediately think, what are the indications? What are the possible scenarios why this patient had mastectomy and not smaller excision like partial mastectomy? So these are the indications for mastectomy. The most common ones I have put on the top in bold. Multicentric, when the tumor is in multiple quadrants. Post-neoadjuvant chemo, that's a very common setting nowadays. At least 60 to 70% of the patients in my department, they undergo neoadjuvant chemo. Inflammatory breast cancer, T4, early pregnancy, local recurrence following partial mastectomy in the past. Once the breast is radiated, you rarely can re-radiate it. So the only option left is complete mastectomy. Briefly, what are the types of mastectomy? Once you have a mastectomy, take a close look at it. Is there a skin? How much skin is there? Is there a nipple? Or there is no nipple. Sometimes there is a nipple and skin-sparing mastectomy. Important, there are only 2 margins in mastectomy. Anterior surface, which is below the skin, or if skin is there, then there is no anterior margin. And then there is a posterior margin. One of the pictures from the mastectomies. So this one is kind of skin sparing, simple mastectomy, which is oriented with 2 sutures. sutures. My surgeons, they put the sutures to orient them. Single is superior, double is this is long is lateral, double short is superior. There's a nipple. This ink is, this dyeing is for the sentinel lymph node. So often when you have a simple mastectomy, the lady, the person will also undergo a sentinel lymph node sampling or X-ray dissection. The dye is from the sentinel lymph node. This is the posterior side. It's ink black. What about the axillary tissue? If you have an axillary tissue in your, as part of your specimens, why would anybody get an X-ray dissection? If there is a clinically node positive in the axilla, which is confirmed by the fine needle or biopsy. Inflammatory breast cancer, T4. Post-neoadjuvant, if the lymph node stays positive after chemotherapy. Axillary recurrence. Those are the common. And what is the typical good number of lymph nodes that you expect in an X-ray dissection? 10. And if a surgeon is doing sentinel and they have submitted 6 or more, it's no more sentinel. It's somewhere between sentinel and X-ray dissection. Just a point, in a post-neoadjuvant setting, the number of lymph nodes removed or identified can be less. And we know that, so that's fine. These steps are important, so you need to orient the breast. Typically, surgeons, they will put some marks. Or breast, it kind of is, it can be oriented easily because it's like an elongated piece. You will have a long axillary tail on the lateral side, and you know it's right or left. Nipple can also help, or the elliptical excision on the skin can also help. The first thing you do is ink it. 2 margins, so you need 2 inks, anterior and posterior. Slicing. This is also important, at least in my setting where we have smaller tumors removed. So we slice it at 3 to 5 millimeter when the breast tissue is fresh. 3 to 5 millimeter. 3 is very difficult, fresh. So 5, 6 is more practical. I have met one person in my career who was my co-fellow. She used to slice breast at 3 millimeter, and I saw it and believed it that breast can be cut at 3 millimeter, fresh. So it's possible. At the same time, you should note down the ischemia time. It's important for your biomarkers. There's a cold ischemia time that shouldn't be more than 60 minutes. And fixation time, that's the next slide. And fixation time is how long does the breast tissue stays in the formalin. So ischemia time is when the breast tissue is removed from the body and put in the formalin, that's the ischemia time. And fixation time is when you put it in formalin and take it out from the formalin. And you need your processor times to calculate the fixation time. And fixation time should be at least 6 hours and not more than 72 hours. And this is relevant if, in my setting, it's not critical because most of the biomarkers are done on biopsies. But if you are doing a lot of biomarkers on the excision specimens, then ischemia time and fixation time are critical. Especially if the tumor is ER negative. Because what happens is if ischemia time is high, then you may be reporting a tumor that is ER positive as negative because deterioration of the antigenicity. Going on to the description, I will show you an example of a case and we'll go over it, how would you describe it. So this is a mastectomy. Typically you start with identifiers, 2 identifiers, designation, measure it, note down the ischemia and fixation time, and then serially slice it. Oh, it's not showing up. This was supposed to be yellow. It's okay. So that's a cartoon where you have oriented it. Center you have a nipple and areola, and in the axilla you have the lymph nodes. So when you're slicing it, don't slice the axilla. So you should stop slicing right where you think the lymph nodes are about to start. Because you don't want to cut through the lymph nodes. It will be difficult to count them. So you slice it, the slices they're showing up, so that's good. So imagine they are like 5, 7 millimeter slices. And then on the right you have an example how it would look after slicing. And then in this particular case we have 3 tumors. And this is how they will look. So you have 3 tumors in 2 quadrants. So you need to measure the size of each tumor, describe the location, distance from each other, and how does the breast tissue look around them and in the other quadrants. So that goes in the description. So this is, now you can take a pause and think about the setting. So this is a multifocal setting. Margins are looking negative because the tumors are far from anterior and posterior surface. Nipple and skin are undermarkable. And you think there may be some suspicious tissue between lesion 2 and 3. And you have the measurements, gross measurements of these tumors. This is just an idea. So you make a plan how I'm going to submit the sections. And this case will have a lot of sections because there are 3 tumors. It's a mastectomy. In my setting, we at least give 3 sections from every tumor. And the goal is to identify the histology or confirm it, what it is, and maybe relationship to the margin, and try to get the entire tumor in one section if it is less than 2 centimeters. If it is more than 2 centimeters, like this big tumor, you take one slice and maybe bisect it and put it into consecutive cassettes so that the person looking at the slides can measure it on the slide. Then you also submit sections in between the breast tissue, 2 sections from the subareolar tissue, and 2 sections from the quadrant that look normal. And these sections also include the orange and the black ink margins, because there are only 2 margins. So how do you gross lymph nodes? So you don't slice them. You can separate the axillary part and squish the fat between your fingers. And you will be surprised. You'll be able to feel the lymph nodes, and then you can just peel them out. You don't have to be very forceful. You don't want to rip the capsule, but that way you can just melt the fat and take out the lymph nodes. And then you can count them. How many do you have? And then serially slice them along the long axis. So this is one of the papers from modern pathology where they tell you how to serially slice them. The guidance is you have to slice them at 2 millimeters. And the way you put them down in the cassette is also peculiar so that you don't miss the smallest micromet. At least in my setting where we do get a lot of microscopic metastasis, this is important. However, it depends on your setting. If you have a lot of macromet, then this may not be relevant. Here's a picture from a normal lymph node, mostly fatty. This is how typically your macromet will look. A white tumor replacing the lymph node parenchyma. So, summary of sections from this case would be like this. And when I was doing this in Philippines, the audience started laughing because they thought these were too many sections. But I think this is kind of an extreme case where you have 3 tumors, a lot of lymph nodes. So you have to, and each of these sections are done in order to get a message, which will go into your report, and that is based on the synoptic reporting of the camp, from the camp. Now, this is something that comes up very frequently when the tumor is very close to the skin. So I'm going to just go over these scenarios. So one of them is Paget disease. Paget is most of the times associated with DCIS, and it in itself is TIS. So often you will have DCIS in the duct, and the cells will be present in the epidermis only. So that's TIS. It's not skin involvement, because skin can look very dramatic, ulcerated or eczematous. That's not skin involvement. That's not T4. A tumor that is sitting just below the skin, one big tumor, directly involving the dermis, overlying skin is intact. This is also not T4, and because overlying skin is intact, it's just a superficial tumor. Another setting where the tumor erodes through the skin, and also it ulcerates the skin, and often the surgeon, your clinician will tell that. They will be able to see it, and that will be T4. Here's an example of a large tumor. This is a mastectomy. Skin is on this side, anterior, posterior. It's a necrotic tumor, and it's directly involving the skin, and it was also radiant. So this would be a T4 tumor. Satellite lesion, where you have a one big tumor in the deeper breast parenchyma, and you have a satellite lesion sitting in the dermis. Often, the surgeon or the clinician should be able to tell you, oh no, oh I'm seeing a message here on the screen. So yeah, the surgeon should be able to pick that, and they will say there is a satellite lesion. And that is related to the lymphatic spread of the tumor to the dermal lymphatics, and that is another T4 stage. This is inflammatory cancer, where you have a tumor in the breast, and you see a lot of dermal lymphatic invasion, and all those dots are the lymphatic tumor emboli in the lymphatics. And often my surgeon, if they suspect it, they will see clinically the yellowish, orangish edematous appearance, and then they will do the skin punch biopsy to confirm the tumor in the lymphatic emboli. Now let's go over this post-neoadjuvant setting, and I see this frequently. At least 60 to 70% of the cases that I see excisions are in a neoadjuvant setting, and they can create their own questions because the tumor that you're going to see grossly is modified by the therapy, and the modification can be a spectrum. Sometimes you don't see any tumor left, and that you see in at least 60 to 70% of triple negative and 60 to 70% of HER2 positive tumors. That's the rate of pathologic complete response after chemotherapy in those settings. If it's an ER positive, HER2 negative tumor, you will still see a lot of tumor left. You don't see complete response. So these are the three examples. So on your right, there's no invasive carcinomas. The shadow is just where the invasive tumor was present, and you may see just a fibrotic area now. So in right terms, there is no invasive tumor bed. In the middle, you have the tumor bed as a white shadow. However, the blue stars are the residual carcinoma. So grossly, the fibrous tumor bed is large, but actual invasive tumor bed is small. And that is relevant because in neoadjuvant cases, you will calculate the RCB score as well as the TNM staging. So your T staging is not based on the white fibrotic tumor bed, but it's based on the residual invasive tumor bed size, which is the blue colored tumor foci. The other pattern is on the right side, where you have scattered foci of residual invasive carcinoma, and they're small usually, but they're separated from each other. And so that will make a difference in how you do the TNM staging and RCB staging. So for TNM, since they are more than 5 millimeters away, you can call them individual separate invasive foci. So that will be multifocal T1, maybe A or B, depending on individual size. For RCB, you will calculate the entire area through which these tumor foci are spread. So that's the big difference between RCB and TNM. Here are the two examples. On the right side, you have a mastectomy, and the brown thing here is the metal clip that is placed during the biopsy, right there. And there is no tumor, it's just loose fibrous tissue. So that's the example of likely no residual carcinoma. This is a different case where you have a lot of fibrous tissue, and it's really hard to tell how much of this is tumor. And so this will be a little difficult case, like how am I going to measure it? I don't know how much of this is tumor, and how much do I submit? This will be easy. If this is less than 2 centimeters, you submit the entire tissue, entire tumor bed. So let's go to our cartoon again. This is the axilla of the lymph nipple, superior, inferior, medial, lateral. If this is your white fibrous area, we map the fibrous area. And in this setting, very important is, I should have said it in the beginning, in a neoadjuvant case, you should know the clinical history. Often they will tell you how big is the tumor bed. And to get chemotherapy, you need to have at least 2 centimeter tumor size. So this is like 5 centimeters, 6, 7 centimeter tumor bed, and it's very fibrous. I don't know how much tumor is there, so I will map it. And we usually submit a section every centimeter. And they are submitted in a sequence so that I can put them together when I'm looking at the slides to give the size of the residual invasive carcinoma. The rest of the sections are representative sections from the normal looking breast tissue from the 3 other quadrants. Same thing, do not serially slice lymph nodes. The process is similar. Well, this is how, this is not a mastectomy, but I just took this to show or share how we map the breast tissue. So you can put the breast slices on a piece of paper, label the slices, and then some sections, and in your cross description you can tell them 2 sections from slice 1, 3 sections from slice 2, and the person who is pathologist is looking at the slides, they can put them together. So this is how it will look at the end for the mastectomy case, post-neoadjuvant chemotherapy. So slices, tissue is submitted from representative slices, and then lymph nodes. Lymph nodes are similar, so expect smaller lymph nodes after a good response. If the patient had positive lymph nodes, they may look very fibrotic. Usually the lymph nodes get smaller. So, but the idea is you remove the fat, squeeze the fat, remove the lymph nodes, count them, serially slice them. And the best is, if you don't see any tumor, you submit the entire lymph node. If you are sure there is a white residual tumor, you can just submit 1 section of representative tumor in the lymph node. I already mentioned this. How do you tackle the lymph nodes? So that's the mastectomy in a conventional invasive tumor and in a setting of neoadjuvant therapy. Now let's look at the other samples. Excisional biopsy and bilocal excision. I don't know how many of these kind of samples you get, but these are mostly where you think the surgeon is thinking it's going to be benign. Fibroadenomas, radial scar. Those are the settings where we get excisional biopsy, or papillary lesions or atypical hyperplasia. They have, most of the times they're not oriented and margins may not be relevant. So what we do is, if it's unoriented, we ink it all black and serially slice it. If it is done for atypical lesions, then we ink the margins if the tissue is oriented. This is the commonest specimen that I get at my place where I practice, breast conserving surgery, partial mastectomy. The only difference between this and mastectomy is this has 6 margins. The tumors are usually smaller, so you have to keep that in mind. These are the indications. 6 margins, so we ink them with 6 colors. They come oriented by the surgeon. Same thing, ischemia time, fixation time needs to be recorded. This is how the typical partial mastectomy looks like. So we have 6 colors. This is anterior, posterior, lateral, medial. This is the inferior side, and there's a green ink on the other side. We have access to the x-rays of these specimens. This is a bracketed excision where the patient likely had 2 specimens and they wanted to remove the both, so they insert the wires before the patient go for surgery, and the surgeons, they go around this breast tissue. So this is a bracketed, localized partial mastectomy. Simple, we serially slice them at 3 to 5 millimeter. We label the slices. This patient had a very small tumor. That's the metal clip that is inserted before the biopsy. So in this particular case, we will submit the entire tumor and represent all the 6 margins. Rest of the breast tissue looks mostly fatty, so some representative sections from the fatty tissue. The good thing is breast is either all fatty or it's fibrous tissue, and you can, by looking at the fibrous tissue, you can make a good guess that there may be a lesion or not. We do get some reduction specimens. Main thing to remember is gross examination is the most important part in reduction specimens. Multiple types of specimens. Scans before surgery. 3 millimeter is the number. So if they see more than 3 millimeter cortical thickening on ultrasound, they think there is a metastasis. So you can use that when you are serially slicing a lymph node. If there is something, a white spot or an area which is distorting the lymph node and it's 3, 4, 5 millimeter, that may be the tumor.
Pathology, exhaustive lecture, like your exhaustive list of sections. Excellent. I have 2 questions regarding staging in the post-neoadjuvant setting. When you have pre-neoadjuvant PET CT scans saying that you have positive internal mammary nodes or a positive supraclavicular node which is sampled, in the post-neoadjuvant setting, obviously we are not sampling them. How do you stage it? Now that, let's say, all the nodes are negative in the axilla, what stage would you give to these students?
I mean, so actually, you can't really do anything about it, right? So if they didn't sample it, I can't comment on it. So I would say it is at least YPT, blah, and P and this. If there is a complete, I mean, the way what I would expect is if it's a complete response in the breast and lymph node, there may be a complete response in the internal mammary or supraclavicular. That's what, but that's an extrapolation.
So you do use the at least. So we use at least also.
Yeah. I
just thought I'll pick your brains and see how you would do it.
Yeah, I would say C note, this is at least this, and then I'll hope that at the tumor board, the tumor board is where we meet every week and discuss the findings that we will talk about it. And I'll be curious, how does the internal memory lymph node look?
The second one is regarding the staging when you have contralateral axillary lymph nodes positive. Our clinicians want us to call it both. They're assuming that the second breast was also tumor, and they don't want to call it M. They want to call it YPTXN. So is that how you do it at your
Yeah, so that's a good question. The reason so I don't know if you understand the question. So there is a tumor on the right side, and there is a tumor in the lymph node, and sometimes you will find metastasis on the contralateral side. That's the question, right? So often I see that in a setting where the lymphatics are either disturbed, either it's a recurrence, either it's the patient had radiation, some situation. So that's the setting. And TNM says that should be measured as a MET. Yeah, I think our clinicians also kind of say, well, I don't want to call it a MET, but I'm forced to call it a MET. But often they don't treat it as a MET because it can be treated locally in the axilla.
Tell us, they say that they've done a mastectomy on the, I mean, whatever, they've even done a mastectomy on the other side. And they say that do not call it M, please call it YPTX. We don't get tumor on the other side as expected.
No, I think that's one way of dealing with it, but interestingly would be the scenario. Why is the tumor on the other side? Is there something wrong with the lymphatics and radiation history? And other thing would be, does the morphology match with the main tumor? Because there can be a scenario where there is actually a tumor on the other side. And if morphology is all similar, then according to CAP or TNM, it's a MET, but if technically it's not a real MET, that's how it has been staged by the agencies.
Last question, if I'm allowed, one last question. In case of DCIS only, how many sections do you take to rule out invasive tumor?
Oh, so that's one of the goals. So if the excision is done for DCIS, you may find invasion. So fan of calcification. So DCIS commonly presents with calcifications, rarely with mass. So I go to my radiology report and will say, oh, this calcifications are 20 centimeters or 20 millimeters. So we will try to submit maybe representative sections from those 20. And if there's no invasion, there's no invasion. I mean, there are some scenarios, so there are some variables which are associated with invasion, like high-grade DCIS, extensive lobular involvement, comedonecrosis, ER negativity. If you have that setting, then you may submit it with more. And if the sentinel lymph node has been done, missing one focus of microinvasion doesn't really make any big difference, except on paper it's T1MI versus TIS. So, but if you're expecting multiple foci of invasion, then, and it's a setting of high-grade DCIS, ER negative, then I would have a low threshold of submitting more. But definitely the idea is to sample the entire stress where you are expecting DCIS. There's no right answer to it, so it totally depends on the case factor.
Thank you, ma'am. Thank you. Thank you, ma'am.
Thank you.
So much for such a knowledgeable session. So here I invite the members from our organizing team, Dr. Jaspreet, Dr. Vinay Kumar, to kindly honor our worthy speaker and worthy chairpersons. A huge round of applause for them, please. Everyone, a tremendous round of applause to them. Thank you so much. So moving on to our next session, that is by Trans-Asia Biomedical, which are our main sponsors. The topic for the session is Update on Hematology, that is to be presented by Mrs. Archana Ravindranath, DGM Marketing. May I request you, ma'am, on the stage for the session?
Good afternoon, respected doctors. It's indeed a matter of great pride to present my talk amidst the presence of such distinguished, eminent stalwarts of the diagnostic industry. On behalf of Trans-Asia Biomedicals, I would like to express my sincere gratitude to the organizers, AIPMA ICP, for giving us this opportunity. Now, before moving ahead with the product updates, a brief introduction of Trans-Asia. Trans-Asia, the #1 diagnostic company, has been serving the IVD industry since 1979. We are in our 47th year, and we are covering the entire spectrum from hematology, clinical chemistry, immunology, critical care, urinalysis, molecular, coagulation, and diabetes, believing in offering reliable, affordable, and innovative medical diagnostic solutions. Our immense reach, not only in India, but even in the global, we have 19,000 plus installations across the country. Yep. And with a 900 plus strong field force, 50 So it's practically 150 plus tests done every second on any transfacial product across the country. In addition, 12 international subsidiaries, and we export to 100 plus countries. Our research and development centers in India, France, Czech Republic, Austria, manufacturing facilities in Daman, Baddi, Seeps, Mumbai, Sikkim, Vizag, Czech Republic. This is our biggest factory, what we have started off with a manufacturing facility in Asia. It's a 4-acre facility where we plan to integrate all the functions of manufacturing, R&D, supply chain to deliver the state-of-the-art diagnostic instruments and test kits. We are going to be producing, at least manufacturing 200 units of FAA per month. This is a new initiative of Transasia in the academics with Irva Global Institute of Medical Technology. The initiative is initiated to offer specialized courses in MBA and MTech in AI-driven diagnostics, genomics, and robotics. Aligned with the Atmanirbhar Bharat initiative, this institution is aligned and focused to reduce import dependency and foster local and Indian innovations. This is situated in Visakhapatnam in the AMTSEC zone or the Andhra Pradesh MedTech zone. Moving on to the new launches, we have this F7100, that is our advanced 6-part hematology analyzer, launched in December 25. As the name suggests, 7100 is for 71 plus parameters and a throughput of 100. The measurement principle for both WBC and reticulocytes are fluorescent flow cytometry. We offer dual mode for RBC, platelet, and WBC, that is in the impedance and optical method. Throughput of up to 100 tests per hour. In the test modes, apart from CBC, TIF, and retic, we offer leukopenic and low platelet mode. We are the only instrument in the country having the AI-Cube technology for distinguishing between the ALL and the AML cases and high linearity. Some of the parameters, apart from the routine differentials and your reticulocyte total panel of retic count, RET-HE, we also have report immature reticulocyte fraction, mean reticulocyte volume, reticulocyte production index, FRC population, hypo-HE, hypo-HE, REWI, Menzer index, all these which are helpful in the anemia classification, immature platelet fraction, immature grands, and some additional parameters like IME or immature eosinophil count for eosinophilia cases, and the LMR, PLR, NLR for inflammation and inflammation markers. Retic panel constitutes of the retic count, the RET-HE, and the different the variants required for giving us a real-time insights into erythropoiesis, the response to anemia disorders, bone marrow failure syndromes, hemolytic disorders. IPF helps in early detection of bone marrow recovery, especially in determining if the thrombocytopenia is to destruction or due to hyperproduction. As we all know that if both IPF and platelet are low, then we know that it is a production disorder, your bone marrow has been hampered. Whereas if you have a high IPF and low platelet, indicates some kind of a destruction which generally takes place in autoimmune disorders. IG or immature granulocyte plays a good factor in prognosis of patients with sepsis or critical illnesses. DNR, as we all know, MLR is a great marker for giving us information on inflammation, a biomarker in several malignancies. LMR or lymphocyte monocyte ratio is helpful in detecting certain tumors, especially of the lung cancers or gastric cancers. PLR or platelet lymphocyte ratio helpful in cardiovascular disorders and autoimmune disorders. HF HPLC or HbA1c analyzer. It's designed to give a throughput of approximately 60 seconds per test in the standard mode and 96 seconds per test in the variant mode. Android system interface has got a gap piercing technology, and it's got a good venting system which can ensure fast analysis, especially reducing the downtime. With an autoloader and NGSP and IRCC traceable results with a CV less than 1%. As you know, the heart of our HPLC analyzer is the column. So this is a very robust stainless steel column which can withstand high pressure, which is required and mandatory in liquid chromatography. 6,000 tests is the column capacity with onboard stability of 9 months. The venting technology is supreme because here generally what is observed in HPLC that air bubbles or you could have microclouds which can sometimes interfere with the system. So we have this venting technology. We can ensure that within 8 minutes that this is taken care of and you can preserve the uptime of the analyzer. This is the chromatograph. As you can see on the left side is the standard mode, the dedicated HbA1c, and on the right with the variant showing HbS, F, D, and E. And the instrument is like placed for processing at least 50 plus samples per day with LIS attached interfacing with all the HB variant flag. And we also command a good service network across the country with our special service and application team. Thank you all for your patient listening. Thank you so much, ma'am, for this session. May I request a member from our organizing team to kindly order. Round of applause for her, please. Thank you, ma'am. Thank you, sir. With this, we conclude the morning session and proceed for lunch. We look forward to welcoming back third category is HER2 enriched subtype where the ER/PR is negative, but these tumors overexpress HER2 and they are treated with HER2 targeted therapy. The fourth category is the triple negative breast cancer, which was previously labeled as laser-like tumors, but these are not synonymous because all triple negatives are not laser-like tumors. This group of tumors, they lack ER/PR and HER2 receptor expression, so thus they are left with no targeted therapy and they are treated with conventional chemotherapy. So since they are lacking these receptors which have targeted therapies, so current treatment is chemotherapy, and despite chemotherapy and even in neoadjuvant setting, if they show good response at early level, they present with distant metastasis, relapse, and they have shorter survival. So this probably can be attributed to the heterogeneous nature of the triple negative breast cancer. So if we do the morphological profiling of triple negative breast cancer, they can be classified into high-grade histological types of triple negative breast cancer and low-grade histological types of triple negative breast cancer. What we commonly see is the high-grade variants of the triple negative breast cancer. These could be high-grade invasive ductal carcinomas of no special type, which will show marked nuclear pleomorphism, numerous mitosis, and they have large areas of geographical necrosis, and most of these are grade 3 tumors. The other feature which we see in triple negative subsets is carcinomas with medullary-like features, and these are characterized by well-circumscribed borders. They have syncytia of tumor with very little stroma, but they are rich in lymphocytic infiltrate. Previously, it was thought that these medullary carcinomas with medullary-like features have better prognosis, and that could possibly be because of high content of lymphocytes in this. In addition, we can have apocrine carcinomas with apocrine differentiation, which means these tumor cells are large, they have abundant granular eosinophilic cytoplasm, but the nuclear grade is high. This group of tumors is also heterogeneous because majority of these are ER/PR negative, but they do show HER2 expression. And subset of these tumors are triple negative breast carcinomas, and they are diagnosed by looking at expression for androgen receptor. And they are usually seen in elderly patients. The other category which falls in a high-grade triple negative breast carcinomas is the high-grade subtypes of metaplastic carcinomas, which include spindle cell carcinoma, where we see it's like a sarcomatoid carcinoma. Tumors have spindle morphology, but they are carcinomas because they have undergone EMT. The other subgroup is squamous cell carcinomas, which is again a subtype of metaplastic carcinoma. And the third category is osteoid producing or matrix producing or chondroid producing triple negative breast carcinomas or metaplastic carcinomas. So if we see even in a high-grade subtype, there are a lot of morphological variants of triple negative breast cancer. Now coming to low-grade histological types of triple negative breast cancer, morphologically they are low-grade, they behave better, but they do share some complex genomic landscape of triple negative breast carcinomas. Again, this has lot of variants which we see at morphology, which includes microglandular adenosis, which can be typical or atypical, and Tesnet cell carcinoma. Then we have a group of slappy gland-like tumors of the breast and low-grade variants of metaplastic breast carcinomas, and entity which is relatively rare, solid papillary carcinoma with reverse polarity. So this is example of microglandular adenosis, which is basically a proliferation of small, rounded, gland-looking glands that infiltrate the adipose tissue. They lack myoepithelial cells, but they do have a basement membrane, and they do not incite desmoplastic reaction. As it looks like a small proliferation of small, rounded glands which are also infiltrating the adipose tissue, morphologically it can mimic invasive carcinomas, but pure microglandular adenosis is taken as a benign lesion. These lesions can show presence of histological spectrum, which includes architectural complexity as well as cytological atypia. So microglandular adenosis ranges from pure microglandular adenosis with atypical changes or microglandular associated The other low-grade triple-negative family member is ethnic cell carcinoma, which is again a low-grade epithelial proliferation, and it shows serous differentiation, which is depicted by presence of zymogen granules, which are eosinophilic. So, as the name suggests, it has a counterpart in the salivary gland tumors, but the ethnic cell carcinoma is not considered under salivary gland type tumors of the breast because they have a different behavior as compared to the salivary gland counterparts. They are not circumscribed, they are more infiltrating, and they have zymogen granules which are more eosinophilic in contrast what we see in the salivary gland type tumors. The salivary gland type tumors of the breast, which includes adenoid cystic carcinoma, secretory carcinoma, polymorphous carcinoma, mucoepidermoid, and adenomyoepithelioma. This group of tumors resemble their salivary gland counterparts both in morphology as well as in the molecular alterations. Like secretory carcinoma in breast and salivary gland, they do show ETD6 and TRK3 variants. And the behavior is similar as we see in the salivary glands. The other category of low-grade variants is the low-grade subtypes of metaplastic carcinomas. And in this group, we have two entities. The one is low-grade fibromatosis like metaplastic carcinoma, which at a casual look looks like fibromatosis because it's showing a lot of hyalinization and thick collagen bundles. And there are some plump cells which you may miss on a casual look, but if you do cytokeratin immunostains, these epithelial cells can be highlighted better. So morphologically, it looks like fibromatosis, but it shows expression of cytokeratin in these entrapped epithelial tumor cells. The other category is low-grade adenosquamous carcinoma, which is a mixture of adeno as well as squamous, and it shows very less cellularity and more of a desmoplastic stroma, and it shows expression of P63 within the epithelial or squamous component. The last category, which comes under low-grade triple-negative breast carcinoma, is a solid papillary carcinoma with reverse polarity, and it resembles the tall cell variant of papillary thyroid carcinoma. It's composed of solid nests of tumor cells, and they have tall columnar cells, and the nuclei, if you see, are not basal, they are towards the apex. So this gives it the reverse polarity appearance, and only about 100 solid papillary carcinomas with reverse polarity have been reported in literature, and we have not seen any of it. So if we see that there is large variation in the histological typing of triple-negative breast cancer, so this should not be neglected because the therapeutic approaches for rare low-grade subtypes of triple-negative are different from those for high-grade triple-negative breast carcinomas. For low-grade triple-negative breast carcinomas, the surgery is sufficient in majority of the cases. So this was about the morphological heterogeneity within the triple-negative breast cancer. At the molecular level also, the triple-negative breast carcinomas show a lot of heterogeneity. Based on transcriptome profiling, these triple-negative breast carcinomas have been subcategorized into different subtypes, which I will discuss in next slides. They show a lot of molecular alterations, giving it a genomic heterogeneity, and they differ from each other in the content of the immune cells. Some are immune inflamed, some are immune cold tumors. So starting with the transcriptome profiling of triple-negative breast cancer, so the same group which gave the molecular classification of breast cancer, Peru et al., in 2010 did a transcriptome profiling of triple-negative breast carcinomas, and they divided it into 6 groups. Basal-like 1, basal-like 2, immune modulatory, mesenchymal, mesenchymal stem cell-like, and luminal androgen receptor. But this classification was recapitulated by Lehman B. et al. In 2011. But after 5 years, they revised this classification, and instead of 6 subtypes, they classified it into 4 subtypes. That is basal-like 1, basal-like 2, mesenchymal, and luminal androgen receptor subtype. Because they thought that immunomodulatory and mesenchymal stem cell lights are actually contributed by the tumor stroma rather than the tumor person. So coming to each subtype,
P53 mutations and BRCA1 mutations. In contrast, the basal-like 2 tumors, sorry, it should be 2. Basal-like 2 tumors, they are enriched in growth signaling factors and they are classified by expression of EGFR and they show alterations in MET and WILT pathway and these are termed as immune activated in contrast to the immune suppressed basal-like ones. The third category of triple negative subtype based on transcriptomic profile is mesenchymal, previously also known as mesenchymal stem cell type or Claudin low subtype. These are the tumors which show features of EMT, that is epithelial mesenchymal transition. They are rich in stem cells and they show downregulation of the tight cell junctions, that is they show downregulation of Claudins as well as epithelial markers. These tumors, since they are showing epithelial mesenchymal transition, they show high cell motility and features of EMT along with angiogenesis and stem cell associated genes are enriched and the Claudins and the cell tight junctions are low. So they have high propensity to metastasize because of high motility and they are resistant to therapies because of stem cell death. The fourth category is luminal androgen receptor subtype and this is enriched in hormonally regulated pathways but it is not ERPR, it is androgen receptor. These tumors show high expression of androgen mRNA as well as androgen protein expression on immunohistochemistry. So this classification was based on gene expression profiling, but gene expression profiling is impractical in routine diagnostics and it's time consuming, expensive, and transcriptomic profiling gives best result when fresh frozen tissue is used rather than the formalin fixed tissue. So people have tried to reproduce this gene expression profiling classification using immunohistochemistry, which is available in most of the pathology labs. It's easier and accessible. And immunohistochemical subtyping of triple negative breast carcinoma can provide information on prognosis as well as to some extent for appropriate targeted therapy as good as the transcriptomic analysis. So we did a study using IHC panel of antibodies and they were done on automation on Ventana platform except for EGFR which was done manually because protease was used to do antigen retrieval. The antibodies which were used are listed here and these were classified as high expression when the total score based on the intensity and percentage positivity of tumor cells were more than 4 and it was categorized as score low if it is less than 4. So this is a panel of IHC. So for basal markers we used CK56 and CK440. So this, if these are positive it will be basal-like 1. If EGFR is expressed it will be basal-like 2. Down-regulation of Claudin 3, Claudin 7 in epithelium and vimentin positivity will be classified as mesenchymal subtype and androgen receptor positivity will be classified as luminal androgen receptor subtype. Despite doing these multiple markers, still there was subtype which remained unclassified and this unclassified category constituted around 24% of the cases. So majority of mesenchymal subtypes which you can correlate with morphology, these are mostly metaplastic carcinomas and around 16% were luminal androgen receptor subtypes. The basal-like 1 had a higher frequency as compared to the basal-like 2 subtypes. So what is the utility of this molecular subtype based on design based on transcriptomic profiling but recapitulated using immunohistochemistry? So it has been seen that basal-like 1 tumors, they have higher response to chemotherapy because they have high proliferative gene signature and the tumor cells are rapidly dividing. In contrast, the basal-like 2, which is immune activated, they show higher sensitivity to immunotherapy. The mesenchymal subtype has a prognostic importance because of EMT features. They show higher rates of metastasis. Because of high stem cell death, they show treatment resistance and thus higher chances of relapse. Whereas the luminal androgen receptor subtype, since it's expressing
drugs. So are we using it in clinical practice? We are not typing them into these subtypes, but now clinicians have started asking for androgen receptor in the triple negative breast cancer subtypes. So we saw that based on the transcriptomic profiling, there is heterogeneity within the triple negative breast cancer subgroup also. The next is genomic profiling, that is looking at the molecular alterations. So people have been looking at these molecular alterations because there is no targeted therapy for triple negative breast cancer. So they were looking for molecular alterations which can be targeted with the drugs available. So it has been noticed that TNBC shows highest overall mutation rate when we compare it with the other subtypes of the breast cancer. So this is whole exome sequencing of a cohort, and we see TP53 and MYC are the commonly mutated genes, and this is a well-known fact that TP53 is the commonest driver mutation which we see in the triple negative breast cancer. But in addition, there was mutations in the PIK3CA gene, and there were mutations in the BRCA1 and BRCA2. So what is the significance of these molecular alterations? We do not have any targeted therapy for TP53 mutated carcinomas, but for PIK3 and BRCA1 and BRCA2, the drugs are available. So BRCA2 and 1 and 2 mutations, they account for only 5 to 10% of the breast cancers which are hereditary. They can be seen in familial breast cancer, which is like when the patients present at a younger age or there is a family history of breast carcinoma. So the tumors which show mutations in BRCA1 and 2, they have deficient homologous recombination repair pathway. So this deficiency is not able to repair the DNA, and it is unable to restore the DNA sequence to its original form, and this leads to genomic instability. So one test for BRCA1 and BRCA2 in triple negative breast cancer. The patients who have genomic BRCA1 and BRCA2 mutations, and if they receive platinum-based neoadjuvant chemotherapy, there is higher rate of pathological complete response in contrast to the ones which are wild type. So clinicians in triple negative breast cancer, they use anthracycline plus they use platinum or taxane-based chemotherapies. So if they are BRCA1 mutated, then they choose platinum-based therapy. In addition to this, there are drugs available for PARP inhibitors. They are not used upfront, but in a metastatic setting or in a relapse setting, the PARP1 inhibitors are recommended to patients who are showing BRCA1 and BRCA2 mutations. And if there is no tumor, they are just carriers, then the bilateral mastectomy is a consideration. So in patients who are lacking BRCA1 and BRCA2 mutations, that they are wild type for BRCA, they look for beyond BRCA, which is like PALB2, JAK2, and ATM mutations, and they look for homologous recombinant deficiency, so that similar treatment can be offered to these patients. We have seen that BRCA1 and BRCA2 mutations are seen only in a limited subset of patients, but most of the tumors in our setup are the sporadic tumors. They are not hereditary or not familial. We have seen that there is downregulation of the BRCA1 protein on IHC, and the mechanism for this downregulation of BRCA1 protein is an epigenetic phenomenon because of the methylation in the BRCA1 promoter region. But this type of downregulation and the epigenetic mechanism which is downregulating the BRCA, are the targets for PARP1 inhibitors or platinum-based therapy is still not clear. The second commonly altered pathway is the PI3-AKT pathway. This is a well-known target for estrogen receptor positive tumors as a second line or upfront metastatic tumors, but its role in triple negative breast cancer is still not clear. So the points where it can get altered are, it can show RTK activation or trans mutations. There can be mutations in PI3K genes. There can be downregulation of PTEN, or there can be a mutation in AKT. So any point where whenever there is any alteration, it leads to multiple cellular processes which include growth, proliferation, and angiogenesis. So in our cohort, what we saw was the presence of PIK3 mutations were and majority were in luminal androgen receptor subtype, mesenchymal subtype, and unclassified subtype. So PI3K can be a target for tumors which are showing androgen receptor positivity, not as a first line, maybe as a second line when they relapse or they metastasize. Post-immune response. And also now clinicians are asking for PD-L1 expression to guide immunotherapy in locally advanced as well as metastatic breast carcinoma. So the kills are estimated in the breast carcinoma using the international guidelines which were published in 2014. So you demarcate the border of the tumor. The inflammatory cells which are outside this border should not be counted. Within the tumor, only the stromal TILs should be counted. The TILs which are over the tumor or intratumoral, they are not to be counted, and you should avoid evaluation of the immune cells in the necrotic areas. Only the viable areas should be counted. And these are the guidelines by the International TIL Working Group given in 2014. So when we assessed our triple negative breast carcinoma cases, they were graded as 1 to 10%, 11 to 50%, only the stromal TILs and more than 50%. So in literature, the lymphocyte rich or lymphocyte predominant breast carcinomas constitute 3% of the cases, whereas in our cohort it was around 15.8% cases. The other thing is looking for PD-L1 expression in the triple negative breast carcinoma. Previously, clinicians were asking for only immune cell score using SP142 clone from Ventana, and this is the range of the immune cell positivity for PD-L1 using SP142, and similar results have been seen with 22C3. So when we are assessing PD-L1 in the tumor cells, we should look only for membranous staining. It can be of any intensity, either complete or partial, does not matter, but it should be membranous staining. But if you are assessing PD-L1 in the immune cells, it should be granular cytoplasmic or membranous staining. Any staining can be taken into account, and we should look for intratumoral immune cells, or you can take the inflammatory cells which are at the border of the tumor stroma junction. And immune score is given if you have to give this particular PD-L1 inhibitor, then the immune score should be more than 1%. But if you are using pembro, then they ask for combined positive score, which is a combination of immune as well as the tumor proportion score. So in our study, we have seen that around 15.8% of cases were lymphocyte predominant breast carcinomas. The mean value of the TILs was significantly higher in the basal group, and the significant expression of PD-L1 expression was noted in the basal-like 2 subtype of triple negative breast carcinoma. So just to conclude, we have seen that triple negative is a heterogeneous disease. It shows large variations in the morphology, high-grade and low-grade triple negative carcinomas. It shows multiple subtypes based on transcriptomic subtyping, which can be recapitulated using immunohistochemistry surrogate panel. It shows molecular alterations dominantly in PIK3 and BRCA1 genes, BRCA1 and BRCA2 genes, and at immune level, it shows immune hot and immune cold tumors. So this can be done easily. We are doing PIK3 mutations using real-time PCR kit in-house, and for BRCA1 and BRCA2 mutations, next-generation sequencing is best because there are a lot of variants present along in all the exons of the BRCA genes. Androgen receptor positive subtypes can be targeted with anti-androgen therapy, and as a second line, we can use PIK3 inhibitors in these subtypes. Basal subtypes which are showing BRCA1 mutation can be targeted with PARP inhibitors, and basal-like 2 which are showing lymphocyte-rich stroma and high PD-L1 expression can be targeted by So the main aim of doing all these things is to look for therapeutic targets for triple negative breast cancer, which has only limited targets. Okay, so this is our group. This pathologist is my senior colleague, Dr. Ashim Das. We had Professor Gurpreet Singh, who is retired now, but these are the two new surgeons. We have a basic scientist, radiologist, and PhD and research fellows, which do all this work. So thank you very much.
Thank you, ma'am, for a very informative session on transcriptome profiling of triple-negative breast carcinoma and keeping all of us awake in post-lunch session. And now house is open for questions, if any. Dr. Aman, thank you very much.
If we are suspecting apocrine morphology, then it is done to confirm that it's apocrine carcinoma. For triple negative breast carcinomas, only if clinician asks and if they are planning to do anti-androgen therapy. And for androgen receptor reporting, we are following the LRAD scoring as we do for ER/PR.
Dr. Bhatt, thank you very much.
Thank you so much, ma'am, for this mind-engaging and informative session. May I now request the members of organizing committee, Dr. Praneet Baka and Dr. Mandeep, to kindly felicitate our esteemed speaker and chairpersons. Thank you. Have a big round of applause. My due apologies to the audience. Due to shortage of time, any questions regarding the sessions can be taken up at the end of the session of the day.
We acknowledge the presence of respected Dr. Vidhu Manjari, a professor and head from this very medical college, a great teacher. And I remember the days when we joined this med school and we were in second year. She was a young and I knew she was more of a heartthrob that time. So please welcome Dr. Vidhu Manjari on stage.
Francisco Puto to grace the dais to receive a token of appreciation. Please pass Dean ICP. May I have your estate, sir, please? Before we begin to our next session, a quick reminder for a banquet dinner at Convert Palms at 7:30 p.m. So let's begin to the next session. Now I kindly invite a worthy chairperson, Dr. Harpreet Kaur, Professor and Head, Employee Stage Insurance, Ludhiana, Colonel Dr. Amulyajeet Kaur, Professor, Gyan Sagar Medical College, you are kindly requested to grace the stage. So as we begin our session on lobular neoplasia, I am honored to call upon stage our speaker, Dr. Kamaljeet, to enlighten us with the topic. I kindly request our honorable chairperson to introduce our speaker, Dr. Kamaljeet.
Good afternoon. Welcome, Dr. Kamaljeet. We've already heard you in the previous session, and it was all very little basic and although very enlightening and very important for many of us out here to know. We already know about him in the previous session. He's from the Brown University, and he's into breast and gynecological pathology, and he's accomplished in his field. I'm sure he's going to speak on lobular neoplasia, and I'm sure you have a lot to tell us. There are a lot of newer insights. Sometimes I wonder, so much of molecular profiling is being done, whether we histopathologists will be needed one day. Maybe the clinicians will come and say, okay, just tell us what molecular type it is. But I think that day will be, hopefully, a little far. Over to you, Dr. Kamal.
Thank you, ma'am, for the kind introduction. Yeah, I won't say I would enlighten you, but I'll try to do my best. Because lobular neoplasia is an interesting topic for me. Yeah, so this is the picture from a paper by Foot and Stewart. And this is the most often if you're reading an article on lobular neoplasia, especially LCIS, inside the lesion, you will, this is a paper where they first described LCIS, lobular carcinoma inside, in 1945. And I really loved it that they gave the credit actually to Ivings. So this is the picture that Ivings had published in 1919. And they said, well, we are describing this entity, but we want to give the credit to Ewing because Ewing was the first one who said, oh, or first saw it. And this is the picture, it's black and white. Now, this is the life story of lobular neoplasia. We know about it for maybe 80, 90 years. And I would assume if there are breast pathologists in the audience, we have sometimes trouble saying, oh, is it lobular or not? Especially when it's invasive tumor. And often you will say, oh, it's invasive carcinoma with ductal and lobular features. trying to figure out what's the best way to pin down the lobular carcinoma. And I would say there is a similar ambiguity when you're dealing with in situ lesions, especially when the LCIS is high grade, and it can very perfectly mimic ductal carcinoma in situ. And so at the end of this talk, if I can just leave you with a little bit of guidance or an impression that maybe if you're looking at in situ carcinoma, that you're thinking it's ductal, it could be pleomorphic lobular carcinoma in situ. That's the one point. And second, maybe give you some guidance on how to identify and diagnose invasive lobular carcinoma as a pure entity. So I don't diagnose invasive carcinoma with ductal and lobular features because it doesn't help my clinicians. They want to know whether it's ductal or lobular. All right. So those are the goals. I actually kind of have mentioned them. I will talk about the E-cadherin IHC. I don't know how many of you do it. Many places where, when I was a fellow, I didn't do E-cadherin my entire 1 year. And we did one IHC on my last day and I was not able to see what was the result. So, but now in my practice we do it very often. So we'll talk about that. So what is ILC? ILC is it's the second most common type of breast cancer. It's the most common special subtype. It makes 10 to 15% of the breast carcinomas. What pins down ILC is the E-cadherin alterations, which leads to disruption of the expression. And because of that, there is a very specific histologic growth pattern characterized by single file of discohesive, small, monotonous tumor cells, often without stromal reaction. So this is the key of this presentation. If you can just remember this, especially the residents and fellows, that's how you diagnose lobular carcinoma. And here's the technique picture. Monomorphic, small round cells, cohesive, and often you can confirm it by loss of E-cadherin expression. There is a positive control on the top. Why is it important to diagnose ILC as such? It's a very distinct clinical disease. It has a very distinct biology. Despite its relatively high prevalence, it is not well characterized, and the reason is we are not able to diagnose it as such many times. Imaging modalities can miss it, they can be suboptimal because it doesn't incite desmoplasia. Often we find it larger than what we had expected. Current WHO classification of the precursor lesions. And then we will talk about the architectural and the cytological variants of the invasive lobular carcinoma. That's where the trouble starts, where the lobular departs away from its typical morphology. So let's do the ALH. ALH. So I'm always interested in why did somebody name something new, right? What's the need of ALH? So this is, I think, 1978, where they were, it's the Rosen, they were trying to study the precursor lesions in mastectomies, and there were two pathologists on the study. And they were trying to identify LCIS, and there were scenarios where the two pathologists did not agree. One would say, well, it may be LCIS, other would say, no, it's not enough for LCIS. And that's how they said, oh, let's call it atypical lobular hyperplasia. However, there are criteria. So this will be ALH, where a part of the lobule is involved by this monomorphic low-grade proliferation. The acini that are involved, they are not distended, and you can still see the lumen. So that's ALH, atypical lobular hyperplasia. It's very subtle. If you can pick every ALH focus, it means you have become a breast pathologist. I already mentioned that. Classic lobular carcinoma in situ, the difference is quantity. So when the entire lobule is involved, their acini are distended and you don't see the lumina, you're looking at LCIS, classic type. And those are the features. I took this from 1945 paper, and nothing has changed much in morphology. So they described really well how does the lobular look. The nuclei are very rounded monomorphic, slightly enlarged, pale, dense cytoplasm, can have intracytoplasmic mucin, and That's how you start thinking about LCIS. Pagetoid pattern is very common in LCIS. What is pagetoid pattern? Where it's the cells, the lobular cells, they creep below the luminal layer of cells, and they're sitting below them and just close to the basement membrane cell. Haggison, who was a surgeon in New York during the same time, he studied the lobular neoplasia a lot, and he classified them into type A and type B because he noticed, just like ductal tumors, there was a grade. There was a difference in nuclear grade. So he classified them into type A and type B. For them, type A were LCIS that were small, rounded, just like your grade 1 DCIS. Type B, the cells were slightly larger, slightly thicker nuclear membrane, tiny nucleolus, maybe slight variation in the nuclear size. So that's type B. We don't use it now. Type A, type B, the WHO doesn't recommend that. Both of them are part of a classic LCIS. Let's go to pleomorphic lobular carcinoma insight, because that's a little problem field where you can diagnose it as DCIS. What is pleomorphic lobular carcinoma insight? As per WHO, you're looking at an in situ carcinoma which has a nuclear grade similar to high grade DCIS. So here's the picture. This one is easy because you can see they're kind of monomorphic, little plasmacytoid, or you can think of apocrine. And nuclear tibia is towards high grade, and they're adhesive. They don't attach to. There's a little space between each of those cells. There's no duct formation, and there is, of course, communal necrosis. When was it first described? 1996. I think the Frost was there, and Silverberg was the senior author. And interestingly, it was associated with a pleomorphic invasive lobular carcinoma, which was ER/PR negative and HER2 positive. So lobulars are rarely HER2 positive. If you take classic invasive lobular carcinoma, only 2 to 3% are HER2 positive. If you take pleomorphic invasive lobular, up to 10, 12% are HER2 positive. Let's look at a case. 56-year-old with suspicious calcifications on mammogram. She underwent stereotactic needle biopsy. Here's the low power picture. Low power picture is very important. So when I'm thinking about lobular lesions, or especially pleomorphic or florid, I think of them as, the way the ducts are distended, they're like loose balloons. You don't see too much desmoplasia. They are almost kind of perfectly rounded and very clustered. There may be communal necrosis. There is no duct formation. Nuclear tibia is high. There are a lot of mitosis. There may be some signal interference. You would think, oh, it's ductal. But the moment there is no duct formation, cells are discohesive, it's time to do E-catering. So I don't have E-catering, but the E-catering there was no membrane staining. This is P120. P120 is, and we'll talk about P120 later. In lobular lesions, P120 is cytoplasmic. There is a normal control, which is membranous. This is a normal duct. So this confirms it's LCIS based on nuclear tibia. It's pleomorphic lobular carcinoma insider. You will perform ER. You don't want to call it DCIS, but this will be managed like DCIS. You will do ER on it. There's no need to do PR or HER2. And I always carefully look for microscopic invasion when you have pleomorphic LCIS. Almost quarter of them have microscopic invasion associated with it. What is florid lobular carcinoma insider? This is another variant, which at one time we used to call it non-classic LCIS. It's more architecture-based classification where the nuclear atypia in LCIS is not high grade. So they are mostly the type Haggison type B cells. The nuclei are kind of grade 2. But the ducts or the lobules that are involved, they are distended and they can have communal necrosis. The clue is there is no duct formation, the cells are discohesive. Recent WHO, based on one paper from West Coast, they said, well, if you just have one duct and there are 40 cells in one line, you can call it florid LCIS. Initially described in 2008 carefully, there's noticed that some of these LCIS have distended ducts and acini, and often they have comminuted necrosis. So invasive focus will be present, so I start looking for invasion as soon as I see pleomorphic or florid LCIS. And unlike your classic lobular carcinoma in situ, if you're dealing with pleomorphic and florid LCIS, the invasive component will always be lobular. They are committed to lobular phenotype. So which is contrast to your classic LCIS where we don't classify it as, we call it PTIS, but we don't measure it, we don't give the span, ER is not needed. This is treated as a true in situ carcinoma. They are very closely related, pleomorphic and florid LCIS. They can have similar clinical presentation with calcifications because of this comminuted necrosis. They can have signet ring cells. At genomic level, they're also related. They have similar hits, including cyclin D1, c-MYC, HER2 amplifications. So they are related. Biomarkers. Classic LCIS is rarely, or I have not seen any ER negative or HER2 positive disease with classic. The moment you have florid or pleomorphic LCIS, the invasive disease can be ER negative or HER2 positive, and even triple negative, which is unusual for lobular carcinoma. Here's an example of HER2 where you have a classic LCIS, which is HER2 1+, 2+, but this is a florid LCIS, which is strongly HER2 positive. Misdiagnosis. I think this is important. Most of the studies that focus on pleomorphic LCIS, they noticed that many of their cases were originally diagnosed and treated like DCIS. So clinically, there is no harm done, but the difference is if you call something pleomorphic or florid LCIS, the initial treatment will be the surgery, which is just like DCIS, but later the adjuvant treatment can be tweaked. Like, does the patient need radiation? That can be tweaked. She doesn't really need to have radiation if it's pleomorphic or florid LCIS. There's a discussion. If you call it DCIS, then definitely the person will have radiation. So that's the one big difference how lobular versus ductal diagnosis can make in the adjuvant treatment. Upgrade rate, what is upgrade? Upgrade is when you have an in situ carcinoma on the biopsy and you find invasion in the excision. So there is a range, up to quarter or more of cases, they show invasion when you have pleomorphic or florid LCIS in the biopsy. So how do you manage them? Once you have diagnosed florid or pleomorphic LCIS in the colorectal biopsy, the surgeon would like to excise it with negative margins, which is like DCIS. If the pleomorphic LCIS or florid LCIS is present at the margin, surgeon may want to go back and remove it. It depends on the case. If there is a lot of florid LCIS, then definitely. If it's ER negative, then maybe. So, and radiation therapy may be considered. So it can be treated like DCIS, depending on the case scenario. But here are the problems. While working on this classic and pleomorphic LCIS, I found it very difficult. Sometimes it's hard to pin down, should I call it pleomorphic LCIS, although the criteria are there. So if the nuclei are, there is a 2 to 3 times variation in the nuclear size, thick nuclear membrane, you can call it pleomorphic LCIS. However, often it's mixed with classic LCIS. You can't really rely on the biomarkers. Morphologically, sometimes it will look like DCIS, and sometimes you're like, wow, well, that can be easily resolved by doing e-catching. I think I've already gone over this, but this is just to show what is the current status. Well, pleomorphic LCIS can be treated like DCIS, so it's important to diagnose it or identify it. Same is true for florid LCIS. So if you have a pleomorphic or florid LCIS in excision, so you have to measure the span just like DCIS and report it in the excision. you have to provide proximity to the margins, how far the foci of pleomorphic and furred LCIS are from the margins. And you need ER and report ER just like PCIS. Alright, next part, the invasive lobular carcinoma, the architectural and cytological variants. And this is the description of typical invasive lobular carcinoma. So if there's first year, second year sitting in the audience, this is what you need, what you're looking for if you are diagnosing invasive lobular carcinoma. Linear infiltration, single cells, targetoid appearance, where the cells go around the ducts, adipose tissue infiltration without any stromal reaction, intercellular disc cohesion. Between the two cells, you will find empty space, windows. Some people call it fried egg appearance. Intracytoplasmic vacuoles, monomorphic nuclei. Mucincles, that's rare. We will talk about that. That's like a variant of invasive lobular. Invasive lobular usually don't make mucin. And if there is an associated ALH or LCIS precursor lesion, then maybe you should say, oh, is it lobular? Invasive lobular carcinoma, is it lobular? So those are the clues for histology. This is how the variant picture appears. So in classic ILC, most of the times the grade is low, the hormone receptors are positive, and HER2 will be negative. These are the architectural variants: trabecular, alveolar, solid, with mucin, with tubular elements, papillary, and then the cytological variants: apocrine, histiocytoid, signature, and pleomorphic. As you go towards these variants, the grade becomes high, receptors become negative, ER and PR, and HER2 becomes positive. This is from 1982. So we knew about these variants, that there are invasive lobular carcinoma variants, and often they have poor prognosis as you go from classic to the solid alveolar variants. This is the pleomorphic lobular carcinoma in the breast, and this one is actually older study. And as a part of human pathology in 1992, and they're just showing if the tumor is pleomorphic, there's a very high risk of recurrence, 4 times, 7 times. And there's a correlation with the normal status, of course. Here's a H&E picture of pleomorphic lobular carcinoma with prominent signet ring cell change. And that's a descriptor. Right now, WHO doesn't have a definite tumor type. Earlier, I think in previous edition, they had invasive carcinoma with signet ring cell change. But since you can see this in both ductal and lobular, there's no distinct tumor. But you see it frequently in pleomorphic lobular carcinoma. This is one of the variants where another picture of carcinoma with signet ring cell differentiation. The cells can have very histiocytoid appearance. They can have prominent mucin vacuole. And I have had couple cases where there was a metastatic colon carcinoma with signet ring cells. So just keep that in mind also. You can have metastatic tumor that can look like ILC with signet ring cells. Stomach, colon. This one is interesting. This is the invasive lobular carcinoma with solid and alveolar pattern. This was an excision biopsy at our outside institution. It was actually called neuroendocrine tumor, because most of the tumor was solid, tight clusters, high power. They do have neuroendocrine type chromatin, salt and pepper. I don't know if you will agree. There are these clefts. They're not terribly adhesive, but there was this odd, I think this is just an artifact, where they were just forming these clefts right leading to the disruption of the section. But whenever you are thinking of a neuroendocrine differentiation in breast, think of invasive lobular solid variant. So this was synaptophysin positive, GARA positive, GCF50 positive. The odd thing was E cadherin wasn't negative, which you want to see for lobular. Most people think, oh, well, to E cadherin it will be dead negative. But 15% of the lobulars don't show that pattern. So, and we will talk about those odd patterns, but this is not normal. It is more cytoplasmic, and there is a perinuclear dot. And people P120 was also similar, not completely cytoplasmic. The clue is you look around, this was another focus where it was very lobular, monomorphic cell, single file. So this was invasive lobular carcinoma with neuroendocrine differentiation, or you can say solid pattern. This picture, this slide has the same tumor on the right side, and this is actually a true neuroendocrine tumor of the breast. So they can look very similar, but think of lobular if you're about to diagnose neuroendocrine tumor. Invasive, this is another histological variant. History was a 70-year-old female. She had a history of breast carcinoma, so this was really a chest wall recurrence. However, the tumor was a little different from what we knew about her. This is, these are the muscle, the skeletal muscle, chest wall, and there are pools of mucin with tumor cells floating in the mucin. They don't look terribly adhesive, they're making loose clusters, and there are some single cells. So first thing will be, oh, it's likely a mucinous carcinoma, like ductal type. So E-cadherin was negative, and P120 was cytoplasmic. So this is invasive lobular carcinoma with extracellular mucin. It's very rare. I don't want you to think about it on every mucinous carcinoma from tomorrow. No, it's very rare. But still to keep in mind. So we had a few cases, we published it, and most of them were older patients, present with mass, large tumors. One of them was small. They were all ER positive. And there was one case had mucinous LCIS too. And the other people have presented similar tumor series. Most of them are one, the doctors, the Schnitt, we have the larger series, 10 cases. So invasive lobular carcinoma with extracellular mucin. This one is can cause problem. This is invasive lobular carcinoma with tubular elements. So you really don't need E-cadherin to make tubules. So lobular carcinomas, so this is a tumor which has loss of E-cadherin, but the tumor cells are making tubular structures. And often they will be very focal and scattered in the corners. Should not be too much. Then you can just call it invasive lobular carcinoma with tubular elements. This is not a mixed carcinoma. Mixed carcinoma is where these tubules will have retained intact E-cadherin. So there is actually true ductal and lobular elements. Lymphoepithelioma-like carcinoma, as I said, lobular is cold or warm regarding to the TILs, but there are rare cases where you can have high TILs, and it can look like a lymphoepithelioma-like carcinoma. So keep that in mind if you have that scenario. Mixed ILC. This is similar to, the concept is similar to ductal tumors, where you have more than one type of morphology. You can call them a mixed lobular carcinoma, invasive lobular carcinoma. All right, I think let's go to the last part, E-cadherin, which is very important. So this is a cartoon which shows where the E-cadherin exists. So these are the two cells, cell membrane, intercellular area. So E-cadherin has this extracellular portion and the intracellular portion. P120, beta-catenin, and alpha-catenin, they are all kind of attached to the intracellular portion. The moment the E-cadherin is dysfunctional, the P120 kind of floats away. Same thing happens to beta-catenin. Normal beta-catenin is at the membrane. Abnormal beta-catenin floats into the cytoplasm, more commonly into the nucleus. I will go through this quick. So E-cadherin came into picture in 1991, but the people who were researching, they didn't figure out that it was a lobular tumor. Later, Moll, he confirmed that E-cadherin loss is only identified in invasive lobular carcinoma. Very important observation they made was that as in a ductal tumor, there is gradual loss of E-cadherin or diminishing of intensity of E-cadherin as you go from grade 1 to grade 3 true ductal tumors, which I keep in my mind if I'm looking at a high-grade tumor. P120 came into picture in 2004. I already mentioned it. Cytoplasmic staining is abnormal. Normally, it's on the membrane. So this will be used in those 15% invasive lobular carcinomas where they don't show complete absence of e-cadherin. The P120 stain can help. This is the paper I think, this is the paper most of the material I've taken, the classification of the architecture and cytology. This is recent one from a European group, and they have a collaborative group on lobular carcinoma. So if you want to read more, this is, I would say, good paper. I think this is one of the last slides where we go over the patterns of e-cadherin. So on top is the axon, you got the molecular structure, the domains, and these are the antibodies that we use for immunohistochemistry, which explains how the staining pattern can depend on what kind of antibody we use. And there are papers on that. So what are the abnormal patterns? Cytoplasmic staining is abnormal. Nuclear staining is abnormal. Dot-like staining that we saw in the solid variant, that's abnormal. Complete but weak membranous staining. Fragmented focal or beaded membranous. Normal staining is like 3 plus 30. Circumferential, strong membranous staining. Key point, you don't have e-cadherin towards the luminal side of the cell. So don't expect e-cadherin towards the luminal side, just like HER2. Beta-catenin, this is normal. Absent is abnormal. P120, membranous is normal. Cytoplasmic is abnormal. Two pictures, complete loss, cytoplasmic. You kind of have to go to high power. This is not intact. This is abnormal. Retained but decreased. This is also abnormal. Can be confirmed with P120, which is cytoplasmic. Solid, that neuroendocrine differentiation. It's cytoplasmic with perinuclear dot. Florid LCIS with some invasion, comedonecrosis has very kind of heterogeneous expression of e-cadherin with some cytoplasmic staining. So this is abnormal. Similar story, putting all the patterns together, and people have studied that, so it's well known. I'm going to skip this. So this was a quick paper where they try to explain why there will be a retained e-cadherin in some lobular carcinomas, and it depends on the location of the mutation. So ultimately, up to 85% of the lobular tumors show loss. P120 can help in those 15% cases. DCIS, ductal high grade, can show reduced e-cadherin and P120. I've already gone through this. I think the key thing is morphology is important. Everything starts with morphology. You have to be sort of come up with some confidence that whether it is lobular or not, and then do your immunohistochemistry. And this table I took from the paper that I cited earlier. So if you wanna, this is very low size font. I'm sorry. If you wanna go over it, it's in the paper that I cited. So I will just leave you that take some effort to kind of diagnose ductal versus lobular more cleanly. Keep in mind that the in situ tumor that you're looking at could be lobular. It may not be ductal, even though it looks high grade and has comedonecrosis and has calcifications. And there are some architectural variants of lobular which can look very ductal. So keep them in mind. Thank you.
Thank you, Dr. Kamalji, for digging deep into the lobular area. Very good and a crisp presentation, I must say. Since the time doesn't permit us to take the questions, so if there are any questions, you can ask them at the end of the session. So now I have the privilege to invite our next speaker, Dr. Ritambra Naga. She is going to speak on vasculitis. I think the talk is probably taken from the cases of the autopsy because she is coming from a place where they have the advantage of looking at the autopsies. So Dr. Ritambra Naga, she has done her MBBS from ITMC Shimla and her post-graduation from PGI MER Chandigarh. And she has also done MN AMS in 1997. Her areas of interest are renal and GI pathology. And she has a lot of extra the areas of interest are renal and GI pathology, and she is a member of many professional bodies, so I will not be taking the names of all of them. And she has got more than publications, many publications to her credit. So it's over to you, Dr. Khan.
Thank you, Dr. Rafi. So as rightly said, I come from an institute, PTI Merge, Chandigarh, where we have practice of performing medical autopsies by pathology residents in cases where we have a very good team of clinicians and a very good lab setup, radiology, but still there are instances where patient dies and we don't have any clue what was going on within the body. So those are, and if as I demonstrate, you will realize what was thought clinically during life and what we saw at autopsy was quite different. So what we learned out of these CPCs, which we conduct every Wednesday, so most of the slides are going to be from the cases which I have presented, and some of them have been borrowed from my friends and colleagues, the cases which had some interesting findings. So I shall demonstrate like how some of the cases had an additional finding in addition to the basic knowledge about vasculitis what we have. So as all of you must be knowing that we classify vasculitis according to the size of the vessels, that is large vessel vasculitis, medium and small vessel. So parenchymal arteries are taken as medium vessels, these smaller ones are small vessels, so capillaries, arterioles, venules, these are small vessels. And aorta and pulmonary trunks are going to be the large vessels. But we have to remember that any vasculitis, a small vessel vasculitis, can involve medium and large size of arteries. And similarly, Takayasu arthritis, which is a large size arthritis of large vessels, can also involve medium or even up to the level of capillaries. So this is the dictum which has to be followed. And this is one of the nomenclature which also all of us have, we know about it. Dominant involvement of pulmonary arteries and even to the level of capillaritis, which was seen in 3 cases. Presence of interstitial lung disease and presence of patient having hematuria but was having Takayasu arthritis. So as you see in this case, the heart is dilated, so he had dilated cardiomyopathy. Along with that, there was unfolding of aorta here, and as we know that Takayasu arthritis is mainly involved the adventitial part of the artery, and you see here from this is thickened adventitia, and there is nibbling of this elastic tissue from the adventitial aspect. And within these areas, a granulomatous reaction is seen, which is against this elastic tissue. So this is a classical representation of Takayasu arthritis or granulomatous arthritis. So I'll just demonstrate once this case. If you see, this is a young female. Clinically, they thought of DIC. Some aneurysms were seen, but they could reach the diagnosis, and the patient had hematuria. Please make note of this. So at autopsy, we had infrarenal involvement of this part of aorta, and as you see, here it is not atherosclerosis. The suprarenal part didn't have any atherosclerosis, and here you see it is very tough. It was difficult to open, and this is what we call Bach-tree appearance, and it was almost stenotic at this point. The osteo of various arteries was normal, and you see there is a thrombus here and an infarct here. So reason for hematuria in this case was not glomerular nephritis, but rather infarct because of involvement of medium-sized artery, which was renal. And rest of the morphology was typical of Takayasu arthritis. So here this is a normal artery, and if you see, these were the arteries of this patient, where we had, in addition to medial destruction, also an insignificant intimal reaction was also there, and there was a granulomatous inflammation at the adventitial point. And very classically, what we see is this kind of a moth-eaten appearance of an elastic tissue of the media. So this is very, kind of a classical when you pick up from in arteries which are affected. And then there were these giant cells and vasa thickened, and this was the area of
mesenteric arteries. Look at these. There is almost 3 times thickening of the adventitia, as seen here, but also make note that there is also an intimal reaction which is occluding the lumina. So those, we know the fact and we believe that Takayasu arthritis is an adventitial disease. But here, in addition to adventitial reaction, we are seeing significant intimal reaction also, and sometimes even almost atherosclerotic-like reaction is also known. In this case, in addition to the small granulomas, we had larger granulomas in the mediastinum, which were, necrotizing, and they were epithelioid-looking granulomas, which also had acid-fast bacilli. So there has been some association of Takayasu arthritis with tuberculosis also. So in this case, it was arthritis with impacting two organs and a significant tuberculosis, which was present in multiple organs. So the tag point here was renal artery involvement causing hematuria. So another case, as you see here, this patient, again a young male, the clinical diagnosis was disseminated tuberculosis, constrictive pericarditis, and some vasculitis was suspected. Radiology at that time was not, probably was not done because it was in 2011. But at autopsy, what we see is again the aortic part, this thoracic part of the aorta. As you see from the adventitial aspect, it was not normal. Normally we see something like this, but there were puckering and there was reaction here. And on opening, we see this kind of a there's unfolding here, and there's dilated cardiomyopathy here. There was a dilatation of both the ventricles. In addition, look at this. The central arteries were completely occluded, and as mentioned, this patient did not have any evidence of cerebral symptoms. So, and microscopy, you see the adventitial thickening, the intimal reaction which I mentioned, as compared to the normal artery. This is normal, but look at this. Instead of this much of adventitia, we have adventitial thickening, and intima, instead of being this only, is thickened and almost equal to medium. So here we could see adventitial reaction and obliterated vasa musora, this multiple appearance of the elastic tissue, with adventitial thickening, and these are those cerebral arteries. Look at the luminal occlusion, but symptomatically there was no evidence in patient of any of these occlusive arteries, and heart also showed evidence of chronic ischemia. In addition, as you see, they were thinking of tuberculosis, but this part of the lung was damaged, and as you see here, there were dilated bronchi, and there were a lot of fibrosis, which on microscopically, as you see, there were obliterative arteries here with this kind of cystic dilatation. At places they had this kind of a bronchial kind of a lining also, and completely occluded arteries. Areas of fibrosis were seen in these areas, and you can see the break in internal elastic lamina, which is a sign of a vasculitis. Once you have loss of elastic tissue, that indicates there has been injury or vasculitic or inflammatory injury earlier on, and there were pulmonary hemorrhages, but no capillaritis in this case. Liver, as expected, because of dilated cardiomyopathy, had this kind of a nutmeg appearance and centrifugal congestion and necrosis. So there have been cases in the past which were documented where, along with Takayasu arthritis, we could have bronchiectatic changes, and in these cases it was postulated that it's a pulmonary arterial involvement which results in secondary bronchial or alterations resulting in this kind of a bronchiectatic changes. So with our experience in PGI, I did older publications from our institute. The pulmonary artery involvement has been documented in number of cases, and these are two studies from PGI, and we see that this pulmonary artery as well as the myocardial involvement both have been documented, and this is a paper from AIMS where again 5.8% can have dilated cardiomyopathy. So thereby meaning to say that cardiac involvement can happen, pulmonary involvement can happen, even pulmonary capillaritis can happen, and bronchial changes which almost look like ILD would be present in cases of Takayasu arthritis and infarct present because of that. And here, this is a fibrinogen stain which is confirming this loss of fibrinogen stain which confirms the fibrin. Now, in one of the cases of lupus, we had similar kind of arthritis and infarct, but when immunofluorescence is done, that shows positivity. That means there could be immune complex mediated pan-like arthritis in cases of lupus. So this is another example where we have class 4 lupus nephritis, but you see this arthritis is present and there was presence of immunoglobulins within these arteries. So this is a pan-like arthritis in a setting of autoimmune condition, that is SLE, and that is how we will make this diagnosis in cases of lupus. Very intriguing case. Again, a 30-year female had inflammatory symptom which indicated that autoimmune phenomena in joints was treated. There were some rashes like this which indicated a vasculitic problem along with the digital infarct. There was a bad obstetric history and inflammatory markers were raised. ANCAs were negative and there were cardiac inflammation as well. Now when this, on angio, there were this kind of a cutoff which indicated that there is presence of some vasculitis here in kidneys and in celiac artery. Now the possibilities which were considered during life were medium vessel vasculitis or Apla syndrome or fibromuscular dysplasia. So when we examined this autopsy tissue, this is from the celiac artery. It was showing us evidence of arthritis here. As you see, there is pacemaker lamina here also. And this is a splenic artery within the pancreas. And you see, it is showing you an intimal bump. There is a damage to the elastic tissue. And what was very intriguing in this case was there was a lot of this kind of a muscle myointimal hypoplasia of the intima. This bump was all composed of myointimal cells. And there was no inflammatory reaction, maybe because it was treated, but this kind of a reaction we have never seen earlier. So there was a lot of confusion. We discussed at length with Dr. David Chen also, who is an expert in polyarthritis nodosa. Finally, it was concluded because there were inflammatory markers which were present that this case was consistent with polyarthritis nodosa only. So this is a splenic artery showing similar kind of obliterated changes. The coronaries, when seen again, had some kind of some evidence of vasculitis at some of the places. These are multiple such seen, and again this myointimal hypoplasia was something weird which we have not seen in other cases at any point of time. So this was some of the surprises you tend to see at autopsies, and myocardium was largely normal. The renal arteries here, as you see, did not show any significant changes, and microscopically was normal. It was expected to be normal because that's why we are considering polyarthritis nodosa. ANCAs was negative, but there can be ANCA-negative vasculitis also. So for that particular reason, glomerular pathology plays an important role along with ANCAs in deciding whether the medium vessel involvement is because of ANCAs or is it purely because of polyarthritis nodosa. So the main renal arteries were something like this, again with the intimal bumps which were very evident with loss of plastic tissue at this kind of points. So finally we decided that this was a polyarthritis nodosa with some atypical kind of a myointimal hypoplasia. It could not be Kawasaki disease again because of this reason, and fibromuscular dysplasia should not have the inflammatory markers which were present in this particular case. Now we had a chance of these three cases, as you see here, they are young patients, had some evidence of some vessel involvement in the form of rash or some autoimmune phenomena in the form of diarrhea. In all these three cases, investigations for inflammation were negative and serologies done were also negative. So in these three cases, after doing multiple sections and investigation, all kind of investigations during life, the diagnoses were either small and medium vasculitis, PUO, and systemic hypertension. But on evaluation at autopsy, what we found that all these cases had coronary
arthritis with ectasias. Myocardial showed either myocarditis or heel myocardial infarction. One of the lungs showed interstitial pneumonia. So what I'm trying to show is that these 3-4 cases, there was no clinical sign to label them as Kawasaki disease because that disease does not have any biomarker. But the presence of coronary artery involvement is something which is kind of seen in Kawasaki disease. So based on these kind of studies in US, now any young patient who has myocardial infarction or any cardiac problem, they do coronary angiogram. If they have this kind of a aneurysmal dilatation or ectasias, those patients are considered to be missed for Kawasaki disease. So as here is an evidence, the coronary arteries are completely occluded. There is ectasia in these coronaries. There is elastic tissue break at places. Some myocarditis was there. Another case again, this kind of aneurysmal dilatation with loss of plastic tissue at some points was seen. Thereby, these cases were labeled as having coronary artery, heel coronary infarct because of coronary arthritis and ectasia because of Kawasaki disease. So we do see this kind of plastic lamina, but no atherosclerosis. These were young patients and there was no evidence of atherosclerosis, which is the most commonest cause of coronary artery occlusion. So renal arteries were also examined. They didn't show any occlusive pathology, neither we had any parenchymal involvement, but microscopically what we see in Kawasaki disease is this kind of edema, some intimal changes, which were present in these particular case as well. So this young female was labeled as having who had essential hypertension, was diagnosed to have Kawasaki arthritis based on coronary arteries mainly, and then there was in addition involvement of interstitial lung disease. So this is one of the papers which states that prevalence of Kawasaki disease in young adults with suspected myocardial infarction, and now there is a victim, any young adult with coronary event should be investigated for Kawasaki disease by doing this kind of angiograms. So lesson learned from these autopsies was that in young patients for hypertensive workup, one needs to do coronary angiograms also, and renal artery involvement can happen in Kawasaki arthritis. Now coming to small vessel vasculitis. Generally, we have granulomatous polyangiitis, EGPA, and microscopic polyangiitis. So that depends upon the clinical symptoms. If there are presence of asthma and eosinophilia with granulomatous inflammation, it is EGPA. If we have upper respiratory tract involvement and granulomatous inflammation with vasculitis, that's GPA. If and lungs having nodules, microscopic polyangiitis does not have any granulomas, has vasculitis, and generally pulmonary hemorrhages in the lung rather than any granulomas or nodules. So then we label them as microscopic polyangiitis, and there could be some situations where there are no ANCAs, so that still it could be a post-immune presented, which could be renal limited. And all this is done in along with the serologies which are to be seen, and extraglomerular vasculitis is seen in very in a regular surgical pathology material. Thank you. Thank you, Dr. Gamra. I do know PGI has some of the best
death syndrome, and it indicates that you are dealing with a negative autopsy, which calls for molecular analysis and autopsy. Now, what are the prerequisites when one is supposed to encounter an autopsy in sudden cardiac death? Apart from age and gender, we have to look at the occupation, lifestyle, and pattern of exercise or athletic activity, the date, time interval, place, and circumstances of death, and look into the past medical history and details of medications, and let us not forget a look into the family history of sudden premature death. We also have to follow a certain sequence for cardiac examination, which would include external examination of the heart, coronary arterial dissection, and inspection of the myocardium, to be followed by opening of the heart by the inflow-outflow technique, inspection of the inflow and outflow tracts, and of the coronary arterial ostia. And once the heart has been cut open, the blood clots have been removed and the heart is thoroughly rinsed. Only then we have to take the heart rate. This then brings us with this basic background to the theme of this presentation, that is sudden cardiac death, which has occurred in the fibrous cap, which is filled with this thrombotic material, which shows the presence of some fibroblastic proliferation, indicating that this person has got both organizing as well as the fresh thrombus. So what are we dealing with? We are dealing with plaque fissuring and occlusive thrombus, which has produced an atherosclerotic epicardial coronary arterial disease. Please also note that in the serial cross-sections of the ventricle, there was also presence of scarring wall, indicating steroids are known to produce subclinical hypercoagulable states. Another case, 14 years male, fainted in the school premises, declared dead on arrival at a nearness of panarteritis, and this panarteritis was produced by a granulomatous inflammation. We call this as tuberculous coronary arteritis, which is an example of a non-atherosclerotic epicardial coronary artery involvement, and we could say it was tuberculosis because there was at the intramural example of small coronary arterial involvement producing sudden death. Unfortunately, the cause for this small vessel involvement could not be ascertained, and other organs also did not show the small vessel pathology. 19 years female, late night onset of shortness of breath and loss of consciousness. This is the serial cross sections of the ventricle from the base to the apex, all of which show the presence of geographic, well-circumscribed to ill-circumscribed, granular gray-white foci, all of which was composed of granulomatous reaction with presence of small foci of necrosis, lymphocytes, epithelioid cells, and Langhans giant cells, nodular tuberculous myocarditis, again an acquired non-ischemic myocardial disorder. 33 years female did not get up in the morning. You saw previously the hypertrophy in that case, but when you look at the hypertrophy here, both ventricles are involved, and when you look closely at the left ventricle, there is asymmetry with the involvement of the anteroseptal region, and on histology, there was not only dizziness at the place of the valvular, and it can produce 36 years male, death in a taxi. This is the end-on view of the mitral valve from the left atrial aspect, and in contrast to the appearance of the scallops of the posterior mitral leaflet, which are bulging into the left atrial cavity, and this bulge is accentuated because of rupture of these caudate tendinae. So what is this? This is a mechanical complication of a mitral valvular prolapse, which would have produced torrential mitral regurgitation and cardiac failure. 38 years female, sudden onset of dyspnea. This is a large opening which is present below the fossa ovalis. So this is not a secondary atrial septal defect, which is seen from the right ventricular inflow tract. There is a history, dietary habits, sedentary lifestyle, substance. Actually, it is not like that. The only problem is that, for example, we have a protocol that we follow in our institute. And I'm sure if this protocol is followed by a variety of centers in India, we are going to come up with the same. Like when I had gone as an examiner, for example, in Rajkot, they also had a 17-year-old female patient. It was in the newspaper, and that patient had tuberculous coronary arthritis. So what I presented is not unique to our center, and if people sit and analyze their own medical legal autopsy tissue material, I'm sure they're going to come up with the same.
I think it's true, and I think this is very important information to come out because
yes,
in the Western world, I do see a lot of the sudden cardiac deaths too in kids, and we do autopsies on those. But the findings are a lot different.
Yes.
First of all, infectious causes are very unusual. Tuberculosis doesn't happen at all there in the Western world in those patients. And a lot of it is genetic predisposition and genetic defects. So molecular diagnosis becomes very significant in those patients. And very often we have that information at the time of, even before the death of the child. So, but I agree, structural abnormalities are the same everywhere, irrespective of the social strata, but genetic testing and genetic defects is different probably in the two sets of population.
If you see in the West, majority of the cases, what I have said is cardiomyopathy, which can produce a structural defect, and close to 30 to 50% are because of ion channelopathies, which result in structurally normal hearts, but they have problems in mutations in the channels of potassium, calcium, and sodium.
The presumed arrhythmic deaths.
Yes.
Very nice elaboration on the Sir, you have shown us that tuberculosis as a cause of a sudden cardiac death. Have you encountered any viral myocarditis as a cause of a death?
I showed you the first case which I showed was viral myocarditis.
The lymphocytic syndrome.
Yes, that one, and that was parvovirus positive. And since we do not do all this, I usually refer my cases to AIMS and to Bangalore for doing the molecular. AIMS for doing the ILC, and molecular is to Bangalore. They are free of cost.
Okay. So were there any cases regarding during the pandemic of COVID-19? Because many times we have heard the news about the sudden cardiac death in a patient of COVID-19.
The problem is that COVID, I think it was even implicated for divorce. So what I feel is that just because COVID came, everything was attributed to COVID. Like aortic dissections, it was because of COVID. So in whatever few autopsies that we have seen with COVID, myocarditis was not a feature. The problem is that many of these autopsies were reported by, I'm not sounding condescending, but many of these cases were reported by people who did not see autopsy material before. So that is why they were very excited and called everything as related to COVID. So from our experience, as well as with Association of European Cardiovascular Pathology, their experience is that there is no myocarditis which is directly related to COVID.
Thank you.
Thank you. my material in 2019 before the COVID started. So this epidemic of coronary artery disease was very well there in India before COVID.
Any experience on the rheumatic heart disease? Young children, so because I have seen few cases of rheumatic heart disease where they were not diagnosed as rheumatic, but brought to hospital.
No, the rheumatic was the usual diagnosis, so I'm not included here. And just put the little more rarer types so that the interest is there.
So, continuing with sir's question about rheumatic, the case which you showed of a mitral valve prolapse, so the cusps were fused and thickened. So, did that case have background rheumatic valvulitis?
No. If you see, there was no fusion of commissures. There was no intercaudal fusion also. So if the commissures are not fused and if there is no subvalvular pathology, I wouldn't call anything as rheumatic.
Do you do microscopy of the mitral valve prolapse also?
All cases have microscopy. And here, actually, I could not show you the photograph. There is this mitral annular disjunction which they describe. Thank you.
Thank you so much, sir. So with such insightful session, we are moved and enlightened. May I now call upon stage Dr. Praneet Kaur Bagga and Dr. A.D. Singh to honor our speaker and chairperson. And give a big round of applause, please. I would like to also call upon stage the judges of the poster presentation, Dr. Neeraj, Dr. Ashdeep Kaur, Dr. Sanjay Kutlani. And we have a big round of applause, please. I truly believe it's a really a Herculean process. With sincere appreciation, I would like to welcome our chairpersons on the stage for the next session. Dr. Mohanveer Kaur, Associate Professor, Government Medical College, Patiala. Dr. Madhu Kumar, Professor, King George Medical University, Uttar Pradesh.
get into the urothelial carcinoma subtypes. We look at bladder biopsies, and most of the time we see some variant of histologies, and then we are not sure how to report those. And we are going to discuss how to report those, how to identify those subtypes, and divergent differentiation. Okay, I have no conflicts of interest. So what's new in the WHO 5th edition, which came out in 2022? We changed the name from variant histology to subtypes, because variant is generally associated with molecular or genomic alterations. So that's why we said, let's keep that to genomic alterations, and we'll call these as subtypes. So before we get into these, let's discuss what's the definition of histological subtype or divergent differentiation. So it is defined as an aberrant histological differentiation other than conventional urothelial carcinoma. It can be pure, which is very rare, or it can be mixed with infiltrating urothelial carcinoma. So what you're going to see is a combination of conventional urothelial carcinoma plus a stripping of some other subtypes. Why it is important? These subtypes can be deceptively bland. They can have unusual cytological features. They can be poorly differentiated sarcomatoid. They can have neuroendocrine differentiation, or they can have unusual stromal response, or varied architecture in the form of micropapillary. So currently, this is how we divide the various subtypes of urothelial carcinomas. So squamous, glandular, and trophoblastic, we consider that to be divergent differentiation. They are non-histological subtypes. These histological subtypes of urothelial carcinoma include nested and large nested, tubular and microcystic, and a bunch of others. But out of these, I want you to focus on the subtypes highlighted in the red brackets, because these are the most important clinically, and these are the ones which are going to have bad prognosis. So if you want to look for histological subtypes, please look for these. These histological subtypes are not rare. These are two papers from earlier in 2007 by Dr. Shah from UT Southwestern, and out of their 448 TORB. In my practice, I see a lot of prostatic neuroendocrine carcinomas metastasizing to bladder, and I always make sure that I add NKX and PSA and some other prostate marker so that I'm not missing a metastatic or prostatic adenocarcinoma. Then adenocarcinoma, which can come from colon, and micropapillary, especially it can come from the ovaries. Ovarian serous carcinomas can have micropapillary architecture. There is prognostic significance. When you have histological subtypes, as I showed you in that paper, they tend to be invasive, they tend to be high grade. So they generally tend to present with locally advanced disease. They have high stage nodal involvement. Urothelial carcinoma with divergent differentiation, plasmacytoid urothelial carcinoma. I'll show you some images, and you will see that these can be very tricky to diagnose and tricky to assess their impact on patient clinically also. There is high risk of understaging in non-muscle invasive disease, especially when you have plasmacytoid mislabeled it as T1 rather than T2 as such. And there is a case for early cystectomy for T1 disease, especially when I give a diagnosis of micropapillary plasmacytoid or sarcomatoid. We may not be getting a full picture, and the urologist will go for early cystectomy rather than giving a trial of neoadjuvant. So let's focus on some of the aggressive subtypes. So what we see here is there is invasive tumor here, right? And we can see there are multiple small clusters within this empty space. The surface. So So whenever you see a urothelial carcinoma in situ, in addition to they was also in the stomach. Yeah. Yeah. Immunoprofile is kind of similar to the urothelial carcinoma, so nothing important here. So this is what I was talking about when they do a TURBT, if they don't go deep, if they skip the muscle, or even when they do superficial tumor and then deep bite, because plasmacytoid subtype is kind of spread across the wall of the bladder. You may not see this portion of the invasive tumor, you might see only this portion of the muscle, and you might call it T1 rather than T2. That's why urologists will go for early cystectomy rather than neoadjuvant chemotherapy. Now moving on, then here what we are seeing is a lot of spindle cells, a lot of pleomorphism. In other areas you can see very pleomorphic cells, abnormal mitotic figures. Clearly this looks like sarcoma. Okay? So this is the sarcomatoid subtype of urothelial carcinomas. It's indistinguishable from sarcomas. It can have heterologous elements like osteosarcoma or rhabdomyosarcoma, and should be reported as prognosis of these tumors is worse. Giant cells and poorly differentiated subtypes, they are very rare. I have probably seen one case of giant cell, and I've yet to come across a poorly differentiated. So when you are going to call something poorly differentiated, it means it is not showing any differentiation towards bladder or any other subtype or any other tumor type. It's not going to stain for anything. Then only you should label these tumors as poorly differentiated. Both of these tumors, they have bad prognosis, so the reporting of these subtypes is important. What WHO has done is they have pulled small cell carcinomas out of individual organ systems and put them as separately in a separate chapter. This is kind of weird, but maybe in the next book they will bring it back. So neuroendocrine carcinoma of the bladder can be small cell, can be large cell. It has all the classical features of small cell carcinoma and large cell carcinoma. I'm not going to go into that, the features. They can be pure or they can be in combination with conventional urothelial carcinoma. They tend to have RB1 mutations. They are aggressive regardless of what's the percentage of these tumors. So it's very important that you identify this morphology and report it. There are about 94% of these are PT2 at presentation, which is a very high number, and they have systemic mets more than 60% of the cases. But always rule out neuroendocrine carcinoma coming from prostate. Now, other subtypes, this is again a whole slide image of the cross-section of the bladder wall, and not much is going on here. There is little bit of activity on the surface, but nothing, we don't see any big infiltrated masses. On closer inspection, what we see is small tubules. And on closer inspection, we see the tumor cells are not very pleomorphic, they are not very aggressive, they are not causing any tissue reaction around these tubules. But if you go deeper, you will see these bland-looking tubules infiltrating the muscularis propria. These tubules will go very deep into the wall of the bladder. This is another example, kind of on similar theme. You have now bigger sort of nests, and again those nests are dipping down. And if you look at the stroma versus this proliferation interface, it's not smooth. You can't draw a line where this proliferation ends and where the stroma begins. So this is large nested subtype, and the previous one was small nested, the subtype of urothelial carcinoma. Again, large nested subtype showing invasion deep into the bladder wall. So nested and large nested, deceptively bland histology. Small nested subtype, you have small round to ovoid nest, may be mistaken for one brood nest. Large nested, medium to large nest with variable borders. These tumors are not an independent predictors of survival when accounting for stage. So it's very important to identify. You can easily miss these tumors in small biopsies, but maybe prognostically these are not that important. Now I want to show you these two images. On this image, do you think this is tumor or not? Yes or no? Tumor or not? What was this focus here? Both of these are small nested.
One is infiltrating.
This one?
Infiltrating.
Yeah. So that's why I put up this picture, because I want to highlight that point again. Let's look at the stromal proliferation interface. I can probably draw a line here, and I can demarcate where stroma starts and where the proliferation ends. Right? In this case, I cannot do that. Right? There's always one or two small glands which are kind of going down. If I'm going to draw a line, it's going to be a zigzag line. It's not going to be a smooth line. Okay? So when you get a small biopsy, this is an important feature for you to remember to make the correct diagnosis of nested pattern of urothelial carcinoma. There's some complication. Alright, now we are moving on to the next subtype. What we are seeing here is small clusters of tumor cells and some small cystic spaces. Okay? And when you see a morphology like this, what differential comes to your mind? Let's say this is not tumor. What would be the most important differential? A small nest of proliferation plus small gland-like structures. Cystitis cystica, nephrogenic adenoma also. So those are the two important differential diagnoses that come to mind. And in this case, on this subtype of urothelial carcinoma, again, you have these kind of cystic structures, but look at the nuclei, it's very bland looking. No mitotic figures, no tissue reaction, they don't look very infiltrated. So this subtype is known as tubular and microcystic subtype. Again, deceptively bland histology, likely closely related to nested subtype. Cytologically bland cells lining tubular or microscopic distended structures, and it can mimic cystitis cystica, it can mimic nephrogenic adenoma. So this is paper from 1996 by Dr. Young, and he described when you have deceptively benign features of urothelial carcinoma, what you should be expecting. If you see nest, it can be benign lesion, then unit is Grun's nest. Similarly, small tubules, nephrogenic metaplasia. Medium-sized glands, cystitis glandularis, and so on and so forth. Okay. Again, Dr. Kamaljeet was describing this, one of the subtypes of invasive lobular carcinoma. Again, what we are seeing is a lot of lymphocytes and scattered abnormal cells. If you do pancytokeratin, and these tumor cells will be highlighted, and they are present in the sea of lymphocytes. On closer inspection, you have all the features of malignancy. There are pleomorphic nuclei, multiple prominent nuclei. So you can identify these tumor cells, but you have to hunt for these. So this is known as lymphoepithelioma-like subtype. sheets and clusters of undifferentiated cells with poorly defined cytological borders, associated with dense inflammatory infiltrate of predominant lymphocytes. Again, it's very important to identify these because they are enriched for PD-L1 expression. So if you make this diagnosis, these patients can be treated with immune checkpoint inhibitors. Then coming on to these rarer subtypes, we see these very rarely lipid-rich subtype, lipoblast-like cells with cytoplasmic vacuoles, indenting nuclei. It can mimic liposarcoma. This becomes a problem, especially when it is in metastatic site. You get a retroperitoneal mass biopsy and you are not going to expect this is coming from bladder. Clear cell or glycogen-rich, it can mimic clear cell renal cell carcinoma. That's the most important thing to remember about this subtype. It's very common for clear cell renal cell carcinoma to have drop-down mets in the bladder. So when you see this type of morphology, make sure you do PAX8 and CA9 and rule out clear cell renal cell carcinoma. Few words on divergent differentiation. You can have squamous, glandular, and trophoblastic. Squamous is important. Giving percentage of these differentiation is important because that is going to decide whether they give neoadjuvant therapy or not. Number of studies have shown that urothelial carcinoma with mixed glandular and squamous differentiation or varied histologies, they do poorly. So it's very important, again, I'm stressing on this point, when you see varied histology, please report in percentages. Another reason for subtype reporting, metastasis often shows subtype histology even if original tumor had low percentage of subtype, conventional urothelial component may not metastasize. If distant metastases are biopsied, subtype reporting on primary tumor help pathologists to recognize a metastatic urothelial carcinoma, especially if you have like lipid-like or liposarcoma. But there are some unresolved issues with subtype histology. Conventional urothelial carcinoma is often mixed with subtype histology, sometimes with more than one subtype. So the current recommendation is your diagnosis should be conventional urothelial carcinoma or high-grade papillary urothelial carcinoma comprising of conventional 50%, squamoid 10%, glandular 20%. That's how you should be reporting these things. I must not be wearing glasses when I put up this image, but these are the various subtypes. Very few words about the molecular diversification of bladder tumors. Just like the morphology, the genomic profile of bladder tumors is very diverse. But you have to remember that if you see a urothelial carcinoma with divergent differentiation or with subtypes, the base of that tumor remains what you see in conventional urothelial plus whatever you see in the subtype or divergent differentiation. If you see pure squamous, pure adenocarcinoma, those are separate tumors. We have tried to divide these bladder tumors into luminal and basal subtypes. Basal subtype is more like squamoid and luminal is more like conventional urothelial carcinoma. But in real life, the distinction is not clear-cut. There is always a spectrum where urothelial, conventional urothelial and squamoid morphology is a kind of intermingle. But if you should be looking for intercellular bridges, you should be trying to find what percentage of tumor has divergent differentiation. I can speak on this. This is basically saying plasmacytoid have CDH1. Difficulties in studying subtypes, they are under-recognized, so under-reported. There is inter-observer variability, lack of standardized diagnostic criteria of cutoff percentage points, and there is sparse genomic data and molecular biology studies. When they did the TCTA for bladder tumors, they specifically said we don't want subtypes. We just want diagnosis of urothelial carcinoma. So we don't have the data of molecular profile of various subtypes. Take-home points, aggressive subtypes have both prognostic and therapeutic implications, especially microbiome plasmacytoid and sarcomatoid, less aggressive subtypes have diagnostic implications, and conventional urothelial carcinoma is often mixed with subtype histology, sometimes with more than one subtype. So report in percentages for these tumors. Thank you.
Thank you, Dr. Mehta, for enlightening us the role of the pathologist, especially to pay attention to the morphology. Because in many centers, even IFC is not available to label these types. So definitely there is a role of the pathologist to give the subtypes.
Bladder tumors are purely morphological diagnosis.
First, muscle invasion is a challenging, then is the subtypes. Thank you so much, sir. Questions, please.
Yes.
Sir, very nice elaboration and giving us a tips how to differentiate these on minute point. Sir, my question is, as you said, most of the neuroendocrine carcinomas, they are from prostate.
No, not most of it, but always rule it out. Rule it.
So how you differentiate the primary neuroendocrine carcinoma from metastatic prostatic? And second is there any role of NKX 3.1 in the neuroendocrine tumors of prostatic ovary?
Depends if it is post-therapy, NKX, PSA, PSMA, all those markers might be negative. But if it is de novo neuroendocrine carcinoma of prostate, then PSA, PSMA might be positive. And you can always do ARC. ARC will be positive in prostate neuroendocrine carcinoma.
Not in urology.
Not in urology.
Thank you.
Pure squamous cell carcinoma and pure black adenocarcinoma, the percentage that you take to call it pure and in which situation?
We don't have that data. I would call pure squamous cell carcinoma in the setting of neurogenic bladder. The patient had been paraplegic for 20 years. In those situations, I see pure squamous cell carcinoma. We don't see pure squamous cell secondary to infectious causes, but I see in neurogenic bladders, I see pure squamous cell carcinoma.
So the ISA 95% cutoff, do you use that?
No, there's no consensus on that. In breast, there are cutoffs. Like if you see more than 90% tubular, you can call it tubular. But in bladder, there is no cutoff. They have done some clinical trials. I'm blanking on the name of the primary investigator. Their cutoff is 50%. Yeah, so they're trying to come into this era of subtype.
And secondly, when you're seeing predominantly adenocarcinoma, do you have a IFC algorithm in the absence, say, of radiology to distinguish urachal versus adeno of the bladder versus mets from the or local spread from the colon?
Yeah, there are no good immunostains to differentiate from bladder to colon. Beta technique can be done, but it's kind of iffy. Yeah, it doesn't
What
work.
do you do in that situation?
We try to do methylation in those situations. Sometimes it works, sometimes it doesn't. And it all depends on the clinical scenarios. Then if the coloscopy is negative, there's nothing in the colon, there's nothing in the appendix or anywhere else, then I would call it, maybe primary bladder.
So you give three differentials.
Yeah. I'm never specific in those situations because I don't have cystectomy specimen. Yeah.
So one thing that I learned recently from a urethral tumor that I had
extreme positive, but not, they were extremely positive also. That's the only series I know. Dr. Reuter published that series. But I don't think the bladder tumors are extremely mediated.
Right. So we can use HPV-DNA or HPV-ish if available.
Absolutely.
Thank you so much. Excellent.
Thanks.
Thank you, sir. It was indeed a privilege to listen to such an informative and impactful presentation. May I now humbly request Dr. Ranganathan, Coordinator EPNA, Dr. Ritambara Nada, Secretary ICP, and Dr. Prameet Kaur Bakka, Organizing Chairperson EPNA, to kindly honor our